I will start my presentation. So thank you very much. It's really a great pleasure to be here at your conference, and thank you very much for giving me the opportunity to talk about specifically systemic therapy in HCC. And as you all know, we have really made tremendous progress in recent years. As you know, I like to show the Esmo algorithm, and we usually treat our patients according to the tumor stage, which reflects not only tumor burden, but also ECOG performance status and liver function, which is really quite important in HCC. For earlier tumors, we apply local therapies with surgery and transplantation. The aim of the treatment is to cure our patients, of course. In intermediate stage, it was the domain of the intra-arterial therapies, TACE, ZIRT, Y90. And in the advanced setting, we are usually applying systemic therapies, and this has not changed and will most likely not change, because here we have vascular infiltration or extrahepatic metastases. I think the most interesting part at this point in time is the intermediate stage, because we have now so many options for systemic therapies, and we know, and I will show you later on, if we sequence systemic therapies, we can really achieve very decent survival for our patients if we can apply them. Of course, this is always a question of liver function. So here in intermediate stage, and we have already implemented this a little bit in our treatment algorithm, we need to decide, is this a candidate really a good candidate for local therapies, or because he has multiple tumors, big tumors, even without vascular infiltration or extrahepatic spread, is he a candidate for systemic therapies? And we named this not suitable for local therapies. In the future, maybe the combinations will get a revival. We have seen a couple of trials in the past which combined intra-arterial therapies, specifically TACE, with TKIs, specifically sorafenib, and these trials were mainly negative, specifically when we consider overall survival as the most important outcome for our patients. And these are 6 trials, the largest trials we have conducted in the last 20 years. And I think we have learned a couple of points here. First, we have not really made tremendous progress when we apply sequential therapies and we combine it with systemic therapies. You can see in the first study with TACE alone, presented by Professor Lobet, we had a median overall survival of almost 30 months. And this has not changed with the latest study that has been published, the TACTIC study by Professor Kudo, where he tried to combine TACE with sorafenib. And also in between, the trials were mainly negative, no improvement in median overall survival. And when you look at the survival curves, I think it's important to understand that if we select the right patients for TACE, we can achieve excellent outcomes with long-term survival, and in some patients, maybe even cure. However, if we select the wrong patients, patients will die very soon, and median overall survival will be disappointing. So in order to improve outcome in intermediate stage with TACE, we need to be very critical in respect to patient selection. I think a well-maintained liver function is key, but also tumor number and tumor size is important. And then we need to decide whether we apply TACE or ZIRT Y90. And this is the progress we have made with systemic therapies. We have now a new benchmark with the Atezo-Bev trial, the IMRAV study, approaching 20 months. And this is really a remarkable progress, considering that with sorafenib alone, median overall survival was less than 1 year. Of course, when you look at the median overall survival in the sorafenib arm, which was the control arm in all of these trials, you can see also in the control arm, median overall survival improved. Most likely not because sorafenib is now a better drug, but because we are now able to apply sequential therapy, and with that, median overall survival is longer. And I was just want to give you one example for combinations. And this is a study we have published last year at Esmo, where we combined TACE with Nivolumab. And our primary endpoint was the overall response rate. We aimed to increase the response rate of more than 50%. You can see it's 71%. And with this, the study was positive. Later at ESMO this year, we will present the updated PFS and overall, at ASCO, we will present the updated overall survival and progression-free survival. So combinations might be interesting. Of course, we need the phase 3 studies, and there are a couple of phase 3 studies ongoing who are looking at different combinations with and without TACE, with and without systemic therapies. And these studies will clearly address this question, whether it's today with the IO-based combination really meaningful to combine the local therapies with systemic therapies. So once we have decided that we would like to use systemic therapies, we need to decide now what should we do. And I think my talk should be a little bit about checkpoint inhibition, dual checkpoint inhibition. And to start off, I think we need to look at the data that have been published for mono-checkpoint inhibition. And you know, the CheckMate 459 study was unfortunately a negative study, despite, I would say, a survival benefit. And you can see that the curves are separating. And we have seen actually very similar data for Nivolumab monotherapy in the Himalaya. So it's a consistent picture. We do know that there are some patients that have a benefit and that there are some patients that live longer compared when we treat them with sorafenib. However, CheckMate 459 was a study designed to show superiority that was briefly missed, unfortunately, narrowly missed. The survival in the sorafenib arm was very long, 14.8 months, and with that, it was a negative study. In the Himalaya study, Nivolumab was, this was a non-inferiority design because the stride regimen, the combination was tested for superiority. So Himalaya was a positive study, and we will need to wait and see whether Nivolumab monotherapy will be approved by the agency. We do have now a new standard of care, and this is the combination of atezolizumab and bevacizumab. I have already mentioned before the new benchmark of 19 months for median overall survival for patients with advanced HCC. We have also seen a longer PFS, which was not so exciting, I would say, but it's almost 7 months. What was really exciting was the response rate for systemic therapies, also a new benchmark. 30% of patients achieved a partial response. So now we are coming closer to the dual checkpoint inhibition and also other combinations, because having seen the atezo-bev data and also the data we have seen for lenva-pembro has sparked the interest in combinations. And here we have 2 trials that have been published: the COSMIC 312 study, cabozantinib, again with atezolizumab, compared to cabozantinib alone or compared to sorafenib. And we also have the Himalaya study, dual checkpoint inhibition with durva-tremi, high-dose tremi, 1 shot, not the 4 times 75 milligram as we have done it in the past. And again, 2 control arms, durva-mono and sorafenib. The data for the COSMIC study, interesting, unfortunately negative. Here again, we have the longest survival for sorafenib, now 15.5 months, which is almost 6 months longer than in the pivotal study, or 5 months longer than the pivotal study with the SHARP study. PFS was significantly improved. In Himalaya, we have the picture the other way around. PFS was not improved, but overall survival was significantly improved with the stride regimen, durva and tremi approaching 16.4 months. So we have 2 negative endpoints and we have 2 positive endpoints. Both trials are formally positive because in the COSMIC study, we had a dual endpoint and PFS was positive. In the Himalaya, we had a single endpoint, overall survival, and superiority was shown for durva and tremi compared to sorafenib. So now I think most likely the combination of durva and tremelimumab will be approved by the agency. It's not yet approved and we have to wait and see. Once it is approved, we would have 4 options. Now we have already 3 options for first-line treatment. And here we need to decide. I think the first and most important question is, are there any contraindication against checkpoint inhibitors, such as liver transplantation or underlying autoimmune condition? Then we have 2 TKIs with high activity, lenvatinib and sorafenib. In case we can use a checkpoint inhibitor, which is certainly the majority of our patients, we have atezolizumab and bevacizumab as a highly effective combination, and maybe soon durvalumab and tremelimumab as an alternative for patients with contraindications against specifically bevacizumab. So when we need to decide now what is our preferred treatment, we need to look at the efficacy data. And today, having more options, the endpoints might be for a specific patient different. I think our most important endpoint is, of course, overall survival. And with atezolizumab and bevacizumab, we have achieved the longest survival ever. So here we have a clear winner. On the other hand, you might also want to consider PFS as an important endpoint, because now if you have a patient with a good liver function, you can sequence the patient and this PFS might add up. And here we have with lenvatinib actually the longest survival ever seen in a phase 3 study, 7.4 months. But also with atezo-beva and atezo-carbo, you have a decent median PFS of 6.8 months. In case you would like to downstage your patient, response rate might be most important. Again, atezo-bev, the highest response rate, but also with lenva and durva-tremo, we have seen decent response rate of 20%. And finally, disease control rate might be an interesting endpoint, because you have a patient, for example, with a high tumor burden, tumor-related symptoms, and you do not want to have progressive disease. And here with sorafenib, 50% of our patients most likely will not respond to treatment. So you would like to aim for a higher disease control rate. And again, we have 3 combinations, the 2 atezolizumab combinations with bev and carbo, but also with lenvatinib, we have a high response rate, and with all 3 treatments approaching 80%. So I think in summary, we have really good options available today with decent efficacy. Of course, we are aiming always for more, sure. But considering from where we came from and considering that HCC is a very chemo-resistant tumor, I think we really have made progress. So I have already mentioned some points for consideration when we decide on first-line treatment. And I just want to briefly touch on one point, the underlying liver disease, because we had a lot of discussions in the past. Can we treat patients with a fatty liver, NASH, NAFLD, with checkpoint inhibitors? And there are some preclinical data by the Heichenwälder group which have shown that there's an exhausted CD8-positive T-cell population which might actually be activated by checkpoint inhibitors, and in the preclinical model leads to more liver injury and accelerates tumor development. And he identified the same T-cells also in humans and presented some data, retrospective data, and the meta-analysis from the prospective data, suggesting that patients with a fatty liver do not have the same benefit as patients, for example, with viral disease. However, I think specifically for the data with the meta-analysis, we need to look more in detail. And I show you why. Here in the IMBRAVE study, you can see the median overall survival in the atezo-bev arm. And in the non-viral group, we have a median overall survival of 18 months, which was actually the shortest in the atezo-bev arm. In contrast, in the sorafenib arm, the curves are also running together, but here we had the longest survival in the non-viral group. And when we compare this to the atezo-bev arm, of course, it's understandable that the hazard ratio is only around 1. Nevertheless, patients with a non-viral hepatitis still have a benefit from atezo-bev. And the same picture in the CheckMate 459 study. Very consistent survival with Nivolumab in all 3 groups, hepatitis B, C, and uninfected. However, again, similar picture as in the IMBRAVE study, very long survival in the uninfected group with sorafenib. So the hazard ratio, which was not in favor of atezo-bev or the checkpoint inhibitors, was mainly related to a longer survival in the control arm, which we do not yet really understand. And having said that, and looking at the data from the Himalaya study, where the STRIDE study was really highly effective in the non-viral group with a hazard ratio of 0.4, I think we do not have any evidence suggesting that we could not treat patients with a fatty liver with a checkpoint inhibitor, and this should not affect our decision-making. So once we have decided on first-line treatment, we need to decide on second-line treatment. As you know, we have approved drugs after failure and progression on sorafenib. However, of course, we would also like to treat our patients after atezo-bev or any of the other new combinations. Here, it's an evidence-free room. Personally, I would strongly suggest, and in line with the national and international guidelines, that all drugs with phase 3 evidence should be used for sequential therapy. In general, we have here two approaches. One approach is we keep the old order. So we use the drugs of the first-line treatment, Lenva and Sorafenib as second-line drug, and the drugs of the second-line trials, third-line drugs. Or we say, okay, we cannot compare the efficacy between the drugs by cross-trial comparison. If we have phase 3 evidence, we can use all drugs. And this is personally the way I would propose. And I think cabozantinib, for example, would be an effective drug in second line after atezo-bev. Sequential therapy is definitely meaningful. These are post-hoc analyses from first-line and second-line phase 3 studies. And you can see those patients that are fit enough. It's, of course, a selection of patients to receive first and second-line treatment are now approaching 2 years, which I think is really good news for our patients. And in the future, the immunotherapies will move to earlier treatment lines. We already see a lot of checkpoint inhibitors tested in phase 3 studies in the adjuvant setting. We have seen small phase 2 studies in the neoadjuvant setting before surgery. The area in intermediate stage, there are a lot of phase 3 studies, combination trials, which I have mentioned before. We are now seeing the first head-to-head trial, checkpoint inhibitors compared to local therapies. And in the advanced setting, there are also very interesting combinations and new drug, tislelizumab in the rational 301 study will most likely present it this year. We have promising combinations like Lenva-Pembro, and we have also concept to continue with checkpoint inhibitors after failure in first-line treatment, such as the IMRAV 251 study, which look at atezolizumab with the TKI after atezo-bev. So with this, I would like to summarize. Multidisciplinary evaluation is key, specifically for patients in the intermediate stage, because we need to identify those patients that should receive local therapies with the aim of cure. On the other hand, patients that are not best candidates for local therapies should receive systemic therapies very early on. We have now a new standard of care, atezolizumab, long survival, good PFS, and high response rate, which will most likely be the control arm in future clinical first-line studies. Sequential therapy is strongly advised. We need to establish the best sequences. I have shown you all these phase 3 studies which evaluate checkpoint inhibitors in the first-line setting. And having so many options, of course, we need biomarkers. At this point in time, we do not have biomarkers, and this is something we need to aim for. And with this, I would like to end. If you have any questions, please feel free to contact me anytime in the future. Thank you very much.
Thank you, Professor Vogel. Kindly stay with us for the discussion and polls. We'll go for the next speaker, Dr. Kanaan Shamari. He's a consultant medical oncologist and director of MENA NCCN Coordinating Center, National Guard Hospital in Riyadh. He will present the role of IO in biliary cancer. Dr. Kanaan, the floor is yours.
Thank you, Prof. Majdi. And I also extend my thanks to Dr. Mirvat, Dr. Abdulaziz for their kind invitation. So I was given the task to talk about where immunotherapy is placed in biliary tract cancers. So I'm going to divide my talk into three major subcategories. I'll firstly talk in general about biliary tract cancers. Then I'll spend quite a bit of time talking about TOPAZ-1 study and some other studies that involve immunotherapy in biliary tract cancers. Then we'll spend the end talking about some upcoming studies. So biliary tract cancers are quite rare. Their incidence is increasing. Now, when we divide them up, we can clearly see that intrahepatic cholangio's incidence is probably the one that is increasing significantly. The prognosis is poor for such tumors, and we know that the 5-year overall survival is less than 20%. Probably this is mainly driven by that most patients diagnosed are at later stages, and one study reported that 70% actually present to you at an advanced stage, and there is a high relapse rate. So treatment of biliary tract cancers. Chemotherapy is usually used in the first-line setting, and chemotherapy really has not changed for quite some time, with cisplatin and gemcitabine being the standard of care and standard regimen for patients who can tolerate this. The median overall survival remains under 1 year, suggesting an area of clinical need. Now, immunotherapy is currently being considered for patients with specific biomarkers. Now, Pimprozumab got a tumor agnostic indication approval for patients with microsatellite unstable tumors or patients with a tumor mutational burden of more than 10 mutations per megabase. PD-1 inhibitors alone show modest activity as monotherapy, and there are a few ongoing phase 3 clinical trials that I will discuss later. So the TOPAZ-1 was actually presented a few months ago at ASCO GI, and it was presented by from Korea. So biliary tract cancers are heterogeneous malignancies. They are the second most group of primary liver cancers, and there is an unmet need due to its aggressive nature and lower overall survival and poor prognosis. First-line therapy remains cisgem, has not changed for over a decade. And based on phase 2 data showing some promising anti-tumor activity with the addition of durvalumab on cisgem, this phase 3 trial was actually expanded and conducted. And there are reports of immunogenicity of biliary tract cancers indicating that this may be a good candidate for immunotherapy. So TOPAZ-1 was the first phase 3 trial that looked at adding durvalumab with cisgem. So they took patients in the first-line setting whose performance status were 0 to 1, who had either intrahepatic cholangio, extrahepatic cholangio, or gallbladder disease, cancer, and they randomized them 1-to-1, almost 700 patients, to durvalumab 1,500 milligrams every 3 weeks, in addition to cisgem, compared with placebo plus cisgem for up to 8 cycles, so 6 months, then durvalumab maintenance versus placebo maintenance. And the primary objective was actually overall survival with the secondary objective of progression-free survival. So their statistical design is that they wanted to do progression-free survival if the overall survival was statistically significant, and I'll mention the results in the next few slides. So in terms of patients who had ongoing therapy at data cutoff, there were much more patients in the durvalumab arm, almost 1 in 5 patients, compared with less than 6 patients in the placebo plus cisgem arm. Main reasons for discontinuation were progression, and more patients discontinued therapy in the cisgem plus placebo compared with durvalo plus cisgem. With regards to demographics, the median age was 64 years, and there were more Asian patients compared to the Western population. So probably more than 55% in both groups. 50% of tested patients were actually ECOG performance status of 0. Now, there were more intrahepatic cholangiocarcinomas compared to extrahepatics, compared to gallbladder adenocarcinoma. So more than 50% of intrahepatic cholangios. And in terms of PD-L1 expression, so tumor area positivity, which is a special test that they did, more patients, so almost 60% of the tested patients had a tumor area positivity of more than 1%. So regarding the primary endpoint, the median overall survival was actually superior in the durvalumab plus cisgem arm, and it was numerically at 12.8 months compared to 11.5 months for placebo plus cisgem. Hazard ratio was 0.8 and statistically significant p-value. Now, when we look at the curves, we can see that they probably start to separate from the month 6. So the hazard ratio for the first 6 months was actually 0.91, indicating probably a 9% benefit or reduced risk of death. However, for the hazard ratio after 6 months, it is significantly better at 0.74, indicating a much benefited group. And of course, the later we go, the better the separation of the curves. So at 24 months overall survival, almost 25% of patients in the Durvalo cisgem arm were alive compared to 10.4 months, 10.4%. Now, when we look at the subgroup analyses, most patients were actually benefited from the addition of Durvalumab with cisgem. However, what interested me is that when you look at the primary tumor location, we can see that intrahepatic cholangiomas benefited the most with a hazard ratio of 0.74 compared to, let's say, gallbladder cancer with a hazard ratio of 0.94. Now, there were more patients that actually had intrahepatic cholangiomas, remember, at 60%. Now, when we look at the PD-L1 expression, so what they did was tumor area positivity, which is combined proportion of tumor cells with PD-L1 membrane staining and immune cells with PD-L1 staining. So this is what they call tumor area positivity. So the higher the tumor area positivity, the better the risk reduction of death. So more than 1% PD-L1 expression or tumor area positivity, hazard ratio was 0.79, compared to if it was less than 1 at 0.86. Now, probably the biggest benefit was at PD-L1 expression, tumor area positivity more than 5% with a hazard ratio of 0.7%. So this is probably what was driving the benefit. If the tumor area positivity was less than 5%, the hazard ratio was 0.88. Now, when we look at progression-free survival, this was also numerically favoring the addition of Durvalumab with a median progression-free survival of 7.2 months compared to 5.7 months with a p-value of 0.001. Now, when we look at the objective response rates, this was also significantly better in the Durvalumab addition to cisgem. And we can see that the objective response rate was 26.7% compared with 18.7%. Now, duration of response was slightly better with the addition of Durvalumab at 6.4 compared to 6.2 months. And the time to response was actually better with the Durvalumab arm, needing 1.6 months to actually get a response compared to almost 3 months for cisgem alone. Now, when we look at the adverse events regarding treatment-related adverse events, there were interestingly less grade 3 and 4 treatment-related adverse events with the addition of Durvalumab. There were also less serious treatment-related adverse events at 15.7% compared with 17.3% with cisgem alone. Now, when we look at your hematological markers, these were less in the addition of Durvalumab plus cisgem, so less reduction in neutrophil count, less neutropenia, less thrombocytopenia, and others. And when we look at grade 3 and 4 treatment-related events, these were actually, in general, overall, less with the Durvalumab addition. Now, when we look at immune-mediated adverse events, expectedly, this is higher with the addition of Durvalumab, with hypothyroidism being the commonest at 12.7%, and rashes being at 6%, pneumonitis and others, so hepatitis, adrenal insufficiency, were all less than 1%. So in conclusion, or the author's conclusion, was that TOPAZ-1 was the first global phase 3 study to report positive results testing immunotherapy plus chemotherapy as first-line therapy in treatment for advanced biliary tract cancers. It did meet its primary endpoint at the pre-specified interim analysis, showing a statistically significant and clinically meaningful prolonged overall survival. Now, it did not show additional toxicity compared with cisgem alone. And the conclusion was that durvalumab plus cisgem is an effective first-line therapy and could become a new standard of care in patients with advanced biliary tract cancers. Now, what I wanted to show you here was the mutational load by tumor type. Now, we know that melanoma, squamous lung cancer, and others have the highest tumor mutational burden. Now, intrahepatic cholangios, median tumor mutational burden is around 2.7 mutations per megabase. Now, when we think about the pembrolizumab tumor agnostic FDA indication, so for TMB more than 10, we know that this occurs in about 5% of your biliary tract or cholangiocarcinomas specifically. And if it's more than 20% mutations per megabase, it is prevalent in about 2%. And MSI high biliary tract cancers occur in about 1% of your biliary tract cancers. So we know that biliary tract cancer is an immunogenic tumor and perhaps a good candidate for immune checkpoint inhibitor therapy, hence the positive results in TOPAZ-1. We know that positive PD-L1 expression on tumor infiltrating T cells was actually observed in more than 50% of patients with biliary tract cancers. So there have been a few trials that actually examined the addition of immunotherapy plus cisplatin and gemcitabine. And I want to shed light here on a few. So one was the BILT-01, which was a randomized phase 2 trial. So it basically tested this combination of 64 patients. Arm 1 or Arm A tested the addition of Nivolumab plus cisgem and had a progression-free survival which was impressive at 7.4 months. Arm B was Nivo-Ipi, and the progression-free survival was 4.1 months. I spoke about the addition of durvalumab plus cisgem, and there was another study, which was a phase 2, that added durvalumab and tremelimumab plus cisgem, and it showed an objective response rate of more than 70%, which is quite impressive, and a progression-free survival of almost reaching 12 months. And cisgem plus toripalimab, which is also a new anti-PD-1 inhibitor. Small study showed that the disease control rate was more than 80%, and progression-free survival was almost comparable with TOPAZ-1, being 6.7 months. And when you look at the waterfall plot to the right-hand side, this shows the cisgem plus toripalimab, showing almost 1/5 of patients actually having a partial response, and more than 60% of patients actually showing some degree of shrinkage in their target lesions. Now, there are ongoing phase 3 clinical trials that are testing cisgem plus some form of immune checkpoint inhibitor. I presented TOPAZ-1, and there's also Keynote 699, which I'll talk about briefly in the next few slides. So I spoke about TOPAZ-1. There's also Keynote 966, which looks at the addition of pembrolizumab plus cisplatin and gemcitabine. They are planning to test more than 1,000 patients, so watch this space. And there's also a trial that is testing the addition of atezolizumab and bevacizumab plus cisgem. So Keynote 966 is going to test cisplatin and gemcitabine plus minus the addition of pembrolizumab compared with gemcitabine and cisplatin alone. And this is going to test patients with advanced or metastatic biliary tract cancers in the first-line setting. The expected number to test is more than 1,000, and the primary endpoint is overall survival. And I definitely look forward to hearing the results of this trial. There's also this trial, which is going to test cisgem plus the addition of atezolizumab and bevacizumab, so an immune checkpoint inhibitor plus an anti-VEGF, compared with cisgem plus placebo plus atezolizumab, so without the Avastin, and they are planning to test it. This is a randomized phase 2 trial, planning to test it on 150 patients. So this may actually show us a signal of efficacy and may be expanded or may progress into a phase 3 trial. So my conclusions from this talk is that TOPAZ-1 is the first positive phase 3 study that reported positive results in biliary tract cancers with the addition of an immune checkpoint inhibitor, Durvalumab. Benefit was higher, or highest actually, when PD-L1 expression TAP score tumor area positivity was actually more than 5%. And benefit was actually higher after 6 months of therapy. We can, if you remember, the separation of the curves happened later after 6 months. And of course, there are upcoming studies in biliary tract cancers that investigate immune checkpoint inhibitor and chemotherapy, and this is exciting. And I'm excited to see the results of the addition of Pimprozumab on top of cisgem. And by that, I conclude. Thank you very much for listening.
Thank you, Dr. Kanaan, for your elegant and new data for biliary cancer that makes us tuned. Thank you. Can you stay with us for the polls and the questions? Now we'll go for the polls. We are very good in timing. Waiting for the polls. First question, did you attend the Esmo, WCGI, or ASCO GI virtual this year? Yes or no? %, yes, 60% no. Next. Did you miss physical, international, and national meetings? Yes or no? Can you show the questions? Did you miss physical, international, and national meetings? Yes or no? Uh, 69% yes and 31 no. They did not miss. Okay, I think all of us have missed. Next. Checkmate 577 in esophageal cancer and esophageal gastric cancer has significant data, mainly squamous histology and PD-L1 more than 5%. Agree? Disagree? Few patients can be candidate for concurrent chemoradiation. %63 agree, 10% disagree, and 27% few patients can be candidate for concurrent chemoradiation. Dr. Abdullah Sharm, can you comment on that? Dr. Abdullah, are you with us? Dr. Ahmed Shuhri.
Yeah, thank you. Bismillah, assalamu alaikum. The study that have mentioned the combination of Nivolumab and 5-FU platinum, the checkmate, actually it is the checkmate 649. So it's not the checkmate 577, but I'm referring to a different study, which is using Nivolumab plus platinum 5-FU. It's mainly used for esophageal squamous cell carcinoma, for tumor cell BDL1 more than 1%. This is what they used in the cutoff limit. But the benefit was shown even in those patients, like all randomized patients, regardless of the BDL1 test. Having said that, the rate of BDL1 positive in that population was around 50%. So 50% were BDL1 positive, 50% were BDL1 negative, and hence the combination Nivolumab plus 5-FU platinum was superior to chemotherapy alone in BDL1 positive and all randomized patients in esophageal squamous cell carcinoma only.
So, do you think this adjuvant treatment you will use for adenocarcinoma also?
Yeah, you are referring to the adjuvant Nivolumab therapy. I would restrict that only to post-surgical patient. So the patient who treated with concurrent chemoradiation had surgical resection. If they have residual cancer, yes, we can use Nivolumab, but not only after concurrent chemoradiation.
Yes, I agree with you. Can you go for the next question, please? Treatment landscape in metastatic gastric cancer is changed with checkmate 649, agree, disagree, abstain. Uh, 78% agree, 10% disagree, 12% abstain. Dr. Ahmed, can you comment, please?
Yes, the only comment I want to know, who are those, the 10%, 12% who disagree and abstain? Yeah, for sure. I mean, these data are practice changing, okay? If you have Nivolumab available in your center, you have immediate access to it. I think the standard of care in the first line setting for gastric cancer is to use the combination of chemotherapy like FOLFOX, CAPOX plus Nivolumab. So yeah, it is practice changing and should represent the standard of care in first line setting in HER2 negative advanced gastric cancer.
I think those who abstain or do not agree, maybe they don't have the access to IO. I think this is the main hindering.
So, Prof. Qadir, can I comment, please?
Yes, Dr. Abdullah.
Yeah, thank you so much. So I totally agree with Dr. Ahmed Shehri. However, we need to keep in our mind the benefit was only for those patients who has a combined positive score more than 5. And definitely for those who is less than 5, the hazard ratio, it was almost 80. So the benefit mainly was for those who combined positive score more than 5 in the first line setting. And I totally agree with Dr. Ahmed and HER2 negative only. So yes, Nivolumab changing practice for those who has combined positive score more than 5. Thank you.
Can we go for the next question, please? Do you do MSI status for all colorectal cancer patients? Yes, no, only metastatic patients. %54% they do it upfront. 18% I think they don't have access for that, and only for metastatic patients in 28%. Dr. Ashwaq, are with us?
Yeah, Amudio. I think should be done, as everybody said, for all metastatic, but still we need to have the MSI status in a stage 2 that will determine sensitivity to chemo. Our patient is not sensitive to chemotherapy. So in stage 2 colorectal cancer, if you have the facility, that will add value in your decision. But if you don't have, or difficult to have the result, I would agree, because also, you know, in stage 2, there is some conflicting data of being resistant to chemotherapy when you are MSI high. So, but I'd rather do it in stage 2 and also in a stage 4 patient.
And is there a difference between those patients who take biopsy from metastatic site or upfront when they were not metastatic on the MSI status? Any changes in that?
The concordance, I know from a liquid biopsy, the concordance was very high. So I would assume like the early or later it will be the same. Again, if you have the luxury of doing another liquid biopsy for this patient for more assessment of molecular, you can do that.
Thank you very much. Next, please. Next question. Keynote 177 Pembro in Keynote 177 Pimprozumab MSI high metastatic colorectal cancer is the standard of care now. Yes, no, I'm still using chemo therapy upfront. %76% yes, 11% no. I'm still using chemotherapy, 13%. I think that most of us agree. What's your comment, Dr. Ashwaq?
I think I would agree with everyone. And you know that immunotherapy have good response. I have at least 6 patients who have extremely good response with first line setting Pembro. But again, we will see some people with high tumor burden, already symptomatic. You might go with induction chemotherapy, then you can leave the immunotherapy later. Again, there is a lot of data of being EGFR mutant, you might have a lesser response, which is I don't believe in that because it's subgroup analysis and we cannot had any conclusion. So I would agree with everyone that almost 80% that immunotherapy should be first line for patient with metastatic MSI high.
Thank you. Next, please. IO in MSI locally advanced rectal cancer, MSI high, unprecedented data, precedent data, phase 2. Agree, disagree? I'm a believer of conventional therapy. Dr. Abdullah Sharm, can you comment? Can be with us to comment?
Yeah, thank you so much, Dr. Kandil. So
We'll
I'm
wait
totally...
first the results. One moment. %77% agree. That's very high for still early data, phase 2. Disagree 9%. I'm believer of conventional therapy 13%. I would say that it would be the opposite. I need to know your Dr. Abdullah and Dr. Ashwaq.
So thank you so much. The data is very complete, actually, and the data is very clear. However, still phase 2 clinical trial, we cannot change our practice based on that. We need to wait for more strong data, phase 3 clinical trial, to change our practice. But the data is very promising.
Yes. Dr. Ashwaq.
I agree with Abdullah, بس ال percentage of agreement حبيتهم شكلهم مقتنعوا بكلامي. I love you guys.
Okay, thank you. Next question, please. Landscape of HCC treatment is changed after IMbrave 150 study as IO upfront. Agree, disagree. I'm still using TKIs as upfront. %86% agree, 8% disagree, 6% I'm still using TKI as upfront. I mean that 86% have access to IO. That's very good.
Yeah, I agree.
Dr. Vogel, can you comment, please?
Yeah, I completely agree. I think it's a new benchmark. Yeah, and the data are really good. Quality of life, safety is good. And with that, I mean, if you do not have contraindications, I think that's the way to go.
Thank you. Next, please. Do you consider dual blockade in HCC patients? I need more data. I'm using TKIs only. Uh, 89% need more data. 11% using TKI only. Can you comment, please, Dr. Vogel?
Yeah, I think the data look good. Yeah, we see that the addition of tremelimumab adds to the efficacy of durvalumab. But when you just do this cross-trial comparison, as I have done it, I think atezobev still looks a little bit better. Yeah, so I think we really need to see more data to understand the subgroups, and maybe with that, it will change in the future. But it's good to have another option, for sure.
Yes, especially in those bevacizumab contraindication.
Yeah.
I think it has a role. Next, please. How do you see TOPAZ data in biliary tract cancer? Promising, not much, waiting more data. Promising in 65%, not much 10%, and waiting more data 25%. Dr. Kanaan, please, can you comment?
course, thank you, Prof. Majdi. I probably would agree that it is promising, and I also would like to wait for more subgroup analyses to see who is the best group that would benefit the most from the addition of durvalumab. I think in clinical practice now, there are many factors that we need to consider prior to initiation of durvalumab in addition to cisgem. One of them is the availability of durvalumab. I know that there are a few hospitals here that do not have durvalumab available. The other consideration is the financial aspects of the institution / the patient. Is the patient insured? Is their insurance going to accept the addition of durvalumab? And of course, the financial toxicity of maintenance durvalumab. That's also to take into consideration. Now, one of the exciting things in this study, at least I found, was that patients with PD-L1 TPS score of more than 5%, the hazard ratio of benefit for overall survival was actually 0.7, meaning they were the ones that actually benefited the most. Now, I know that Prof. Vogel was actually one of the investigators of this trial, and I'm actually interested to hear his comment on the trial as well.
Yeah, so I think you really did a great job and presented the data as they are. And I think we have to acknowledge it's the first positive IO trial, phase 3 trial in BTC, and it's only the second positive trial in the first-line setting. So it's a really difficult to treat tumor, and I think any progress we made is an advantage for our patients. Yeah, of course we would like to see more, but we have a statistically significant improvement. Safety profile was good, so if it's approved and available, I will use it.
Thank you. And I also know, I actually looked at some selected abstract that will be presented in ASCO this year in a couple of weeks. And I know that Topaz one updated analysis will actually be presented.
Yeah,
thank you.
Indeed. We additionally will provide some data on the regional differences. I mean, this is something we discussed in the past and might also help to understand the data a little bit better.
Thank you.
Thank you, Dr. Kanaan. Now we will look for questions. We have a few questions for Dr. Vogel. Some asking about your first-line treatment according to your lecture for advanced HCC with patient with fatty liver.
Yeah, so as I have said, I think that was a very interesting paper by the Heichenwälder group, but we do not, we use checkpoint inhibitors in patients with fatty liver, and we have seen great responses, yeah? So I think the data that were included in the paper were specifically for monotherapy, but today I think we moved on and we have now the dual checkpoint inhibitors, the combinations with atezolizumab and bevacizumab, and also cabozantinib maybe. So, and I think for these combinations, with the data we have at the moment, I will use them. So if we really think that these data are important, we need a prospective trial to address this question specifically. So far, we only have post hoc analyses and have shown you that differences are mainly derived by the control arm. So for me, NAFLD and NASH patients are treated with checkpoint inhibitors.
Another question, in your practice, which patients you use TACE and IO?
Yeah, that's a very good question. Actually, we have 2 clinical trials where we have the opportunity to use these patients. And from what I have seen so far, I really think that the responses look really good and better than before. But I mean, it's still only a couple of patients, but I have shown you our IMMUTACE study with a response rate of 70%, which is really promising. But I think the most important question now is, does this translate also in a longer survival? And I'm not sure. So we really need to see the phase 3 studies to implement it in clinical practice. At this point in time, I would only, or we are only doing it within clinical trials.
Thank you. And for Dr. Ahmed Al-Shuhri, what's your first-line treatment for MSI high metastatic gastric cancer, and if you use IO in first line, which is the second line?
Yeah, excellent question. For the MSI high gastric cancer, if the patient doesn't need an immediate response and he's a fit patient, I would still stick to the FOLFOX plus Nivolumab, because the data in MSI high gastric cancer showed that this combination, FOLFOX or CAPOX plus Nivolumab, was extremely kind of beneficial as compared to chemotherapy alone. If the patient is not a chemo candidate, or if the patient is a bit frail to receive chemotherapy, I would go with Pimprozumab, because we have data, Pimprozumab in the first line setting, and there was a clear benefit of having Pimpro in the first line in comparison to chemotherapy, as per the Keynote 062 study. So a fit patient, I would go with chemo plus Nivo. Borderline patient, not fit or doesn't need immediate response, I would go with Pimpro. What to do next line? I would go with the standard like chemotherapy in the second line. So for example, the patient was started on Pimprozumab, I would use like chemotherapy doublet, like platinum 5FU, if not being used before, or I would go with paclitaxel, ramucirumab if the patient was treated with CAPOX plus Nivolumab or FOLFOX plus Nivolumab.
For Dr. Kanaan, do you do NGS testing for biliary cancer routinely? And if a patient has evidence and MSI high use?
Sorry, I missed the first part, Prof. Qandil. Your voice was cutting off. Can you repeat your question? I'm still able to hear.
Can you open the quick
do NGS routinely for your patients? NGS.
Okay, sure. So do I do NGS routinely on all biliary tract cancers? I think for intrahepatic cholangios, we should be using NGS. Do we use it in our center? Yes, we do. We have our in-house NGS and we have our send out NGS, and we routinely would use them for intrahepatic cholangios. So looking for targetable mutations, FGFR, and others.
And you have access for drugs for FGFR2 fusion, this kind of...
I mean, if your question is, are they formulary, Prof. Qandil? No, they're not. But if we get them, yes, we can, yes.
Okay. Okay, thank you. I think for the sake of time, we have to end this polls. Thank you for all the speakers.
Dr. Qandil, excuse me, I have a question.
Okay.
My question, and I have a comment. My question to Dr. Ashwaq and Dr. Abdullah Sharm about the metastatic rectum. When I saw the title of the immunotherapy in advanced rectal cancer, my impression is that the metastatic rectum is different in the treatment than left colon. We have now a strategy for the right colon, left side, right side. So the rectum will be another entity for specific treatment for metastatic.
Usually, most of the data for metastatic colorectal are lumped together. Yani if you're gonna look for data specifically only for rectal metastatic, you will hard find it as a solo data. For most of the data we get for colorectal, and since the title is immunotherapy and colorectal cancer, I think the point that we're talking about, it's beyond like right and left, which is more toward biologic. And we know right-sided, probably they carry more the MSI high patient, and there are probably the people that they might respond to therapy. But again, we tackled all the immunotherapy, whether MSI high or stable, because we have challenging and a lot of data. Again, if we look at neoadjuvant and metastatic, there are two different aspects. And when I received the topic, I thought I'm gonna gather these two because advanced rectal cancer can be locally advanced or metastatic.
Okay, for the locally advanced rectum CA, the integration of the radiotherapy with the immunotherapy, we have two schools for the radiotherapy as a preoperative radiotherapy. The American school to give long course of the radiotherapy with low dose, 25 fractions, 50 gray on 25 fractions, about 1.8 or 2 gray per fraction. This is low dose. But the European school, we have the short course, 25 gray over 5 fractions, or 28 gray over 5 fractions. This is high dose per fraction. The high dose per fraction induce the immune system and give more immunogenic for the cells. So my opinion from the radiation point of view is that if you need to integrate the radiotherapy with the immunotherapy, it's better to give the high dose per fraction, to give the European school 25 gray over 5 fractions, then the immunotherapy, rather than the long course of the radiotherapy with low dose per fraction.
Yeah, I heard you. Yeah, I heard you. I think I'm not a radiation oncologist, so whatever you're talking about, the doses for me is another science. But I think your point is very valid, because in the clinical trial that showed that patient immunotherapy with chemorad, they have no benefit, patient with chemotherapy benefit. Maybe that's explained by whatever you've said about the dosage. I don't think we have a huge clinical trial or phase 3 trial of integrate these, and probably looking at this part of the dosage will be very important. بس هذا اللي اقدر اقوله الكلام بتاع radiation I don't know anything, but I think it's a valid point, دكتور. الله يعطيك العافية.
Thank you, Dr. Abziada. I think for the sake of time, they are calling me to end this session. Thank you for the speakers and moderators. Now we'll leave the floor for the satellite symposium. I would like to introduce Dr. Fahd bin Shamsa, who is a senior consultant medical oncologist and chair of Oncology Center at King Fahd Specialist Hospital in Dammam for his satellite symposium. Dr. Fahd, please. The floor is yours.
Thank you very much, Prof. Majdi, and thank you for all moderators and speakers of the GI session. It was really outstanding and very informative. I would like also to thank the organizing committee and scientific committee for this wonderful event that's been successful year after year, and thanks to BMS for inviting me to moderate the satellite symposium. We are privileged to have Dr. Ahmed Al-Shihri as a speaker with us in this satellite symposium. Dr. Ahmed Al-Shihri is a consultant, adult medical oncology, and section head of adult medical oncology in King Abdulaziz Medical City in National Guard, Jeddah. He will talk to us about new horizon in treatment upper GI cancers and the era of immune therapy. Dr. Ahmed, thank you for being with us as a speaker today.
Thank you, Dr. Fahad, for the nice introduction. I would like also to thank BMS for inviting me to talk about the role of immunotherapy in upper GI cancers. This will include esophageal and gastric cancers. This is a slide that I actually borrowed from my dear colleague, Dr. Abdullah Sharm, and it actually shows the global cancer statistics from the Global Con website for the statistics of 2018. You can see that gastric and esophageal cancer may represent up to 9% of all cancer incidence incidence across the world. And with regard to mortality, they present almost like 13 to 14%. Whenever you see the mortality rate is close to the incidence rate, it means that this is a very aggressive kind of cancer, and there are a lot of unmet needs that need to be addressed. Here in Saudi Arabia, probably I have shown that in my previous slides, that esophageal and gastric cancer represent almost 5% of all male cancers diagnosed in 2016, and almost 2.5% of all female cancers diagnosed in 2016. So when we talk about gastric cancer, as I mentioned, it's a highly aggressive cancer where mortality rate surpassed actually the incidence rate, which indicate that this is a very aggressive cancer with a high mortality, and we need to have more novel therapies to address the depth of this problem. And this is why we have so many biomarkers nowadays that we use in our clinical practice to help us choose which one of these like systemic therapy would be the best for our patients. We have the HER2, we have the MSI, we have the PD-L1. These three are mandated now in clinical practice. We have now the tumor mutational burden, which is another biomarker for the benefit of immunotherapy. And of course, at later lines of therapies, we have other rare mutations like INTARC mutation and so on. So talking about immunotherapy in gastric cancer. So now I'm talking only about gastric cancer. I will leave esophageal cancer to the end. So talking about immunotherapy in gastric cancer, let's start with the third line setting, okay, to be like immunotherapy to be used among like in the third line and beyond. So this is the Attraction 2 study, which is a well-known study using Nivolumab versus best supportive care in a phase 3 trial. As you can see, that the vast majority of patients were actually ECOG 0 to 1. You can see the vast majority were gastric cancer, more than 80%, versus 18% gastroesophageal cancer. And you can see that those are heavily pretreated patients. Believe it or not, 80% they received 3 lines or more of chemotherapies before they have been randomized to this study. You can see that the overall response rate is around 12%. The median survival rate has improved from 4.1 months to 5.3 months in favor of Nivolumab, with a hazard ratio 0.62, with a significant p-value of less than 0.0001, which is quite significant. And the Nivolumab, as you can see, has reduced the risk of death by 38%. This is really significant in heavily pre-treated population. And you can see that this kind of benefit was independent of PD-L1 status. So whether the patient was PD-L1 positive or negative, there was a trend to benefit for the Nivolumab as opposed to best supportive care. And we can see the 2-year follow-up of this study. We can see that those patients who had like partial response or complete response, they derived most of the benefit of Nivolumab as opposed to those people who have a stable disease. Stable disease, they still benefit from Nivolumab. But if the patient has some degree of response, whether partial response or even complete response, the benefit is really huge in those population with a median survival that has exceeded 2 years. Again, in heavily pretreated population, as we mentioned. Another agent that have been used in the third line setting is Pimprozumab. And you can see it was a single arm study, 200 milligram Q3 weeks. You can see that the response rate, progression-free survival, overall survival is quite comparable to Nivolumab. Having said that, if you look into like the categories of these patients, we can see the benefit of Pimprozumab was limited to those who have PD-L1 positive disease, as scored by CPS of 1 or more, and those only who have used Pimpro in the third line setting. Okay, so those who use Pimpro beyond third line, they didn't get a lot of benefit, and those who have MSI high tumor. So there is a benefit to Pimprozumab in the third line setting. However, it's a conditional kind of benefit. It has to be CPS of 1 or more. It has to be third line exactly, not beyond. It has to be MSI high. As opposed to Nivolumab, the benefit was shown across all these subcategories and regardless of PD-L1 testing. So these are the immunotherapies that we can use in the third line setting. Nivolumab as per the Attraction 2, with improvement of overall survival and progression-free survival, unconditioned benefit. Pimprozumab, there was a benefit but it was conditional to those who had PD-L1 positive CPS of 1 or more, third line setting, not beyond, and MSI high gastric cancer. What about second line? Second line, there was a study using Pimprozumab versus paclitaxel in the second line setting with a primary endpoint of overall survival, progression-free survival in those with CPS of 1 or more. This study did not meet its primary endpoint, but when they went back to do subgroup analysis and post hoc analysis, they found that those patients with a score of CPS of 10 or more, they derive benefit. And of course, those who have MSI high, they have a benefit with a hazard ratio 0.42. So once again, the benefit of Pimprozumab in the second line setting is conditional. So it has to be CPS score of 10 or more or MSI high. And there is a limitation of this study that the primary endpoint was not met as we mentioned. So you can see in PD-L1 negative, there was no benefit of Pimpro. Actually, Pimpro was inferior to the chemotherapy, which is paclitaxel. And in CPS more than 1, there is no benefit of Pimpro over paclitaxel. The benefit was only in MSI high and CPS more than 10. Okay, so you have to be careful with these data. What about first line? First line, there was a study also of Pimpro in the first line setting. It was a 3-arm study, Pimpro alone, Pimpro plus chemo versus chemotherapy alone. And once again, the primary endpoint was for CPS more than 1. The primary endpoint of this study was not met. However, again, when they looked into those who have a CPS score of 10 or more, there was a benefit of Pimpro as a monotherapy as opposed to chemotherapy. But there is no benefit of adding Pimpro to chemo over chemotherapy alone. So this study was not a really straightforward study because the primary endpoint was not met. However, the Pimpro monotherapy was beneficial on those who have PD-L1 score of CPS of 10 or more and those who have MSI high, like gastric cancer, as we saw in the second line setting. So if you ask me, can I use Pimpro in the first line setting? I would say yes. For me, I would restrict that use in MSI high gastric cancer and those who doesn't need immediate response rate and those who don't tolerate chemotherapy. Now we'll come to the landmark study, the Checkmate 649, which is the use of chemotherapy plus Nivolumab versus chemotherapy alone. The chemotherapy here was FOLFOX/CAPOX. There was a third arm using combination of Nivolumab and Ipilimumab, but it was closed because of toxicity. So now we are limited to chemotherapy alone or chemotherapy plus Nivolumab. There was a dual primary endpoint here, overall survival and progression-free survival in PD-L1 positive of CPS score of 5 or more. Okay, and you can see most of the patients were Asians. Actually, most of the patients were non-Asians, 75% versus 25% Asians. Most of the cases here were gastric cancer. Here you have to notice that almost 10 to 15% were esophageal adenocarcinoma. Why this information is important? Because the NCCN has included this protocol as a treatment for esophageal adenocarcinoma. Okay, so the vast majority were metastatic gastric cancer. You can see the MSI rate was 3 to 4% in this population. This is the primary endpoint, which is overall survival in CPS of 5 or more. You can see it was statistically significant in favor of use of Nivolumab plus chemotherapy. The median survival has improved from 11.1 months to 4.4 months with a hazard ratio 0.71 with a p-value of less than 0.0001. So this is clearly significant and should represent the standard of care in most of our patients. Not only this, the survival benefit was also shown in those patients who have CPS score of 1 and more, and even in those like all randomized patients, regardless of PD-L1 testing. But remember that even when you talk about all randomized patients, that more than 80% of those patients were PD-L1 positive with a score of 1 or more. So you can extrapolate from this data that Nivolumab plus chemotherapy is beneficial for CPS score of 5 or more, but also can be used for those who have less than CPS score of 5. The progression-free survival, the same kind of story. There was a clear benefit of using Nivolumab plus chemo in CPS more than 5 and all randomized patient, and the same for the response rate and duration of response was beneficial for CPS of 5 or more and all randomized patients. This is very interesting slide about the MSI high. So we have no doubt if you have an MSI high gastric cancer, the benefit of use of immunotherapy in those patients very significant. But most interesting part of this story that even microsatellite stable gastric cancer, there is a clear benefit of adding Nivolumab to chemotherapy. So some people might have this kind of conclusion that if you have microsatellite stable gastric cancer, we shouldn't use immunotherapy. No, these data confirms that addition of Nivolumab to chemotherapy is beneficial even in microsatellite stable gastric cancer. You can see deterioration of symptoms have been delayed by using Nivolumab in addition to chemotherapy, and the quality of life was better by adding or was not negatively impacted by addition of Nivolumab to chemotherapy. Toxicity profile, the Nivolumab, it did not add that much to the toxicity of chemotherapy. So most of the these toxicities are quite manageable in clinical practice. So to summarize immunotherapy in gastric cancer, if you are talking about third line and beyond, the most compelling data were Nivolumab as per the Attraction 2 study. It was a phase 3 trial, Nivolumab versus best supportive care, and the benefit was regardless of the PD-L1 testing. The other option is Pimprozumab. However, the benefit of Pimpro is conditional, meaning that it has to be either MSI high or PD-L1 of CPS score of 10 or more, 1 or more, or it has to be third line exactly, not beyond third line. When we talk about second line, the only agent of immunotherapy that had been used second line was Pimprozumab. Again, it was conditional for CPS score of 10 or more and MSI high gastric cancer. First line, the most compelling data actually is the use of combination of Folfox or Capox plus Nivolumab in CPS score of 5 or more. And also in all randomized patients, there was a benefit. And in MSI high and microsatellite stable gastric cancer, there was a benefit. Pimpro as a monotherapy, I may consider that in MSI high gastric cancer if the patient was not a chemo candidate or the response rate is not badly needed in these patients. So immunotherapy in gastric cancer, I think the Checkmate 649 is a practice changing. It is a published study and should represent the standard of care as a first line treatment in most gastric cancer patients, unless you have a contraindication for this kind of approach. Okay, and it had been added to the NCCN guidelines as a preferred approach for the management of gastric cancer. And as I mentioned, the Capox or Folfox plus Nivolumab has been added as a treatment option in esophageal adenocarcinoma in the NCCN guidelines based on these data. Then we'll move on to the esophageal cancer. Okay, esophageal cancer, we can use immunotherapy in the second line setting. We have the Keynote 180, which have shown that the Pimpro is beneficial in esophageal cancer, mostly in PD-L1 positive and mostly in esophageal squamous cell carcinoma. And this is why we have the Keynote 181, which is a randomized study using Pimpro versus single agent chemotherapy, either paclitaxel, docetaxel, or irinotecan. As you can see, when we talk about esophageal squamous cell carcinoma, there was a trend to benefit, but was not statistically significant. But in CPS positive of a score of 10 or more, there was a clear benefit of Pimprozumab as opposed to chemotherapy in the second line setting. And that kind of benefit was histology dependent. So in esophageal squamous cell carcinoma, the benefit was more than adenocarcinoma. So the best outcome of using Pimpro in the second line setting would be in CPS positive patients of score 10 or more and in esophageal squamous cell carcinoma. The other agent to be used in the second line setting is Nivolumab. There was a study, the Attraction 1 study in esophageal squamous cell carcinoma. So this is limited to squamous cell carcinoma. You can see the response rate was almost 17%. And this has led to a phase 3 trial, which is Attraction 3. in esophageal squamous cell carcinoma, Nivolumab versus single agent chemotherapy, docetaxel or paclitaxel, with a primary endpoint of overall survival. As you can see, there was a clear benefit towards Nivolumab as opposed to chemotherapy, with absolute difference of 2.5 months in favor of Nivolumab. The overall survival has improved from 8.4 months to 10.9 months, with a hazard ratio of 0.77 and a significant p-value of 0.019, which was statistically significant. And again, the same story, that this kind of benefit was independent of PD-L1 testing result, which is another additional value of using Nivolumab, that you don't have to test for PD-L1. What about the first line treatment of esophageal cancer? There have been 2 landmark studies. One of them is the Nivolumab plus Ipilimumab, or Nivolumab plus chemotherapy as opposed to chemotherapy. It's a 3-arm study. One of them is Nivo plus chemo. The other one is Nivo plus Ipi. The third line is chemotherapy alone, and the primary endpoint was overall survival and progression-free survival in tumor cell PD-L1 of 1% or more. As you can see, the vast majority here were Asian, actually, like 70 versus 30%. This is the primary endpoint of the study. You can see that there is a huge benefit of using Nivo plus chemo as opposed to chemo alone. So the addition of Nivolumab to chemotherapy has improved the overall survival. And this was true for PD-L1 positive and also for all randomized patients, regardless of PD-L1 testing. The progression-free survival also was beneficial for PD-L1 positive. Remember, the definition here is tumor cell PD-L1 more than 1% is different than the gastric cancer definition. What about the combination of Ipilimumab and Nivolumab? This is the combination. You can see for the overall survival, in the first 6 months, the chemotherapy arm was superior, but post 6 months, there is a clear benefit of using the combination of Ipilimumab and Nivolumab as opposed to chemotherapy. And this was true for PD-L1 positive and for the all randomized patient, regardless of PD-L1 testing. And the question we should ask ourselves, is there a population of patients who can be treated with immunotherapy without need to go for chemotherapy based on these data? I will leave the answer to you guys after having seen these data. Regarding toxicities, most of the toxicities, whether talking about Nivolumab or Nivo plus Ipilimumab, are manageable, and we see that in our clinical practice, and we don't have any new toxicities that have been reported in this study. Remember, the dose that have been used here is different than the dose that have been used in the gastric cancer. When we talk about the dual immunotherapy, the dose that have been used here, Nivolumab 3 mg per kg and Ipilimumab 1 mg per kg. So if you consider the dual immunotherapy, this would be the dose that you can use. The last study that I want to shed light on is the Pimprozumab plus chemotherapy versus chemotherapy in esophageal cancers. Remember the difference between Nivolumab study and Pimpro. The Nivolumab study was purely esophageal squamous cell carcinoma. Here is esophageal squamous cell and adenocarcinoma. And they have used Pimprozumab plus chemotherapy, 5-FU and platinum versus 5-FU platinum chemotherapy. You can see this is the primary endpoint, overall survival in all randomized patients. There was a clear benefit and statistically significant benefit of adding Pimpro to chemotherapy. When we talk about esophageal squamous cell carcinoma, also the benefit was shown there. This is the benefit in PD-L1 positive with a score of CPS of 10 and more. You can see the benefit was even more. However, all randomized patients have got the benefit of adding Pimpro to chemotherapy arm. And this is the progression-free survival. Once again, we see a benefit of adding Pimpro to chemotherapy arm. And that kind of benefit was more pronounced in CPS more than 10. You can see that despite the fact that we have seen the benefit across all patient population, but the benefit was mostly restricted for those who have a CPS of 10 and more. And the benefit was shown in adenocarcinoma and squamous cell carcinoma. You can see that duration of response and overall response rate has improved by adding Pimpro to chemotherapy. So the quality of life also was maintained, so was not detrimentally affected by adding Pimprozumab to chemotherapy. And with regard to toxicities, all of them are related to the chemotherapy. The Pimpro did not add that much to the toxicity profile. So if I want to summarize the immunotherapy in esophageal cancer, in the second-line setting, the most compelling data actually was from Nivolumab as per the Attraction 3 study, and this is only in esophageal squamous cell carcinoma, which was shown to be superior to chemotherapy in the second-line setting. And the second data we have is the Pimpro based on the Keynote 181, and this was esophageal adenocarcinoma and squamous cell carcinoma, but the benefit was mostly shown in those who have CPS score of 10 or more and squamous cell carcinoma. For the first line, we have Nivolumab, the most compelling data for Nivolumab plus chemotherapy as per the Checkmate 648, and it only was for esophageal squamous cell carcinoma. The benefit was shown in PD-L1 positive and all randomized patients. The same for Pimpro plus chemo in the Keynote 590, and this did include adenocarcinoma and squamous cell carcinoma, and the benefit was shown in all randomized patients, but especially in PD-L1 positive, the benefit was even more superior. So both of these studies, the Checkmate 648 and the Keynote 590, are practice changing, in my opinion, and should change the practice of esophageal cancer, whether squamous cell or adenocarcinoma. And as I mentioned, most of these chemotherapy protocols have been included in the NCCN guidelines to be ready to be used in the clinical practice as soon as possible. With that, I would conclude my talk, and thank you for your attention.
Thank you very much, Ahmed, for this outstanding presentation. You showed very convincingly that immune therapy has transformed the landscape of treatment in upper GI in different lines of treatment. Of course, we're more importantly, the first line. You showed very interesting results, especially the Checkmate 649. So adding Nivolumab to either FOLFOX or Zelox improves survival more than 3 months, also improves progression-free survival, and also improves CR rate up to 11%. That was very interesting. And really give us an example of this like transformation in the landscape. And what I like about this study that they use the chemotherapy that we are extremely familiar with, Zelox, FOLFOX. So did it matter in this study for those patients if they use Zelox or FOLFOX? Did they do any analysis about the chemotherapy backbone?
Yeah, to be honest with you, I didn't come across this kind of difference. I mean, between the chemotherapy backbone, like in this study, 50%, almost 50%, they use Capox, the other 50%, they use FOLFOX. If you want to go from all the studies, not this one, as I mentioned, the capecitabine-based chemotherapy was shown to be superior to 5-FU-based chemotherapy, but this cannot be drawn from this particular study. But some people might believe that Capox might be more active than FOLFOX, and I may personally prefer to use Capox plus Nivolumab every 3 weeks as opposed to FOLFOX plus Nivolumab. But from this particular study, no, I didn't come across that Capox plus Nivolumab is superior to FOLFOX plus Nivolumab.
Excellent. Dr. Walid Al-Sulwi, can we have mic for Dr. Walid, please?
Thank you, Dr. Ahmed. Excellent talk. I'm just asking regarding the, as Dr. Fahd and you mentioned, the immunotherapy Nivolumab in the first line setting. We know that approval for more than CPS more than 5. What is about your practice, and Dr. Fahd, if patient with more than 1 gastric cancer, are you still for those patients, or we have just only for patient more than 5 CPS?
You want to go, Fahad, or should I go?
So I think for the sake of approval, it's approved for more than 5.
Exactly.
Although Ahmed showed very nicely in the clinical trial the data, and the benefit was universal. And I think it's a trend in many tumor sites that you can predict better response with the higher PD-L1 expression with different testing. But yet, I think in this talk, I think we're bound to the approval of more than 5, Ahmed.
Exactly. I totally agree with Dr. Fahad. For the sake of approval, we might restrict our talk about those who have CPS score of 5 or more. But if you go to the data, there was a benefit even for a score of 1 or more, and even for all randomized patients. And the FDA, the American FDA, has approved it regardless of CPS scoring. So just to keep it.
Yet you showed very nicely that most of patients are already like they have good expression. Yeah.
Exactly.
Dr. Majdi Gandil, Prof, very happy to see you. And a question, please go ahead.
Yes, thank you, Dr. Fahd, and thank you, Dr. Ahmed, for your elegant presentation as usual. My question for both of you, we have, and you have mentioned that there is a percentage of complete responders. And my question is, in your clinical practice, both of you, if you have a patient with complete response, or partial response or stable disease for a long time. When you stop both the Nivolumab or Pimprozumab, when do you stop the drug for the complete responder and for the partial or stable disease response?
That's a tough question, Dr. Prof. Kandil. With regard to, I just adopted this kind of practice with regard to chemo plus Nivo. So I have few patients on this kind of treatment. Some of them, they achieved a good response, but not to the level of complete response. But theoretically, if I have a patient with complete response, most of these studies that have tested the immunotherapy, they went up to 2 years of this kind of treatment. So let's say that if I cross the 2 years kind of treatment on immunotherapy, usually I drop chemotherapy after 6 months of treatment. If the patient showed a good response, I continue immunotherapy as a sole agent. If the patient kept having a good response to that. At 2 years interval, I may sit with my patient. I may discuss with him the continuation versus holding the treatment and keep observing. I'm talking about those who have achieved complete response. But those who still maintaining a stable disease for a long time, personally, I don't prefer to stop treatment. Continue even if the patient cross the 2 years kind of interval. I would like to hear also my colleague, Dr. Fahad, what would be his opinion about this?
Thank you, Ahmed. You answered really perfectly this question. I think it all goes back to the discussion with the patient, as you said, and goes back to how is the patient tolerating this treatment from different aspects, even the commitment to clinic visits will be tested, and then a decision will be taken. For me, I'll be hesitant to stop to stop treatment if this patient is really maintaining complete response. Maybe beyond that, maybe more than 2 years, 3 years, maybe then I will be discussing with the patients. If you allow, Dr. Abdulaziz, we have a question.
Yeah, you go through an esophageal and gastric about non-metastatic disease. As you said, I think believe in the definition non-resectable.
That's true.
I know you go through faster through like the trials, but what about the local therapy, i.e. radiotherapy? Do they permit it? And if they permit it, where's the timing compared to immunotherapy, given that also there is a lot of agreement on the abscopal effect of radiotherapy and the immunotherapy?
That's a good question, Dr. Abdulaziz, but to be honest with you, I didn't come across the effect of local therapy on those patients who have unresectable disease. And I'm not quite sure if the data also stratified according to those who have metastatic disease versus those who have locally unresectable disease. Those who have locally unresectable disease, they present like 7 to 8% of the total population. So I'm not quite sure even if we do subgroup analysis for those patients, we would have like a good, but I totally agree with you that the local therapy might impact the whole benefit here. But I didn't come across the answer to your question. It's an excellent question though.
Dr. Ahmed Al-Shehri, thank you very much for being our speaker in this satellite symposium. And thanks BMS for sponsoring and inviting both of us to participate in this event. Thank you all for your attention and time. I think it's lunch time and prayer. So we'll be 1 hour and we'll be back at 1:30. Thank you.
You said at 12:30, so 11:30 now.
No, it's 11:30. It's 12:30.
Oh, hi, it's Tom Poles. Can you hear me? Hello?
Yes, I can hear you, doctor.
Oh, hi. What time am I? Have I got my timings right? I've just looked at my diary and I've got my time as being now, but I'm guessing that's not right. Is that correct?
No, isn't right.
When
it
would
isn't
you like
right.
me to do this?
In 5 minutes, they will receive the session, and after 45 minutes, your talk time will be.
Oh, so I'm talking in 45 minutes. So I'm coming in 45 minutes from now.
Yes, yes, Dr. Right.
Okay, that sounds good. Do you need me to stay? Shall I join back in 45 minutes?
You can join back in 45 minutes if you have something to do, any other thing to
What's
do.
my sound and vision like? Are you comfortable with it?
Everything is clear and good.
Okay, I'm just going to share my screen to make sure that works, if I may.
Okay.
Is it sharing okay?
Yes.
So everything's working. This is unbelievable. I'm 45 minutes early and everything's working. I'm in a parallel universe.
Exactly.
All right, lovely. Look, I'm not going to turn anything off, okay?
Okay. Okay.
And I'll just be here in the background. Thank you very much indeed, sir.
Thank you, doctor. Thank you.
Bye-bye.
Not bad, baby.
Just depends what time my thing is this afternoon. Are you still on? You're not on the mute, by the way.
محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Good afternoon, ladies. Dear colleagues, it gives me a great pleasure to introduce the next session, which will be for GU cancers. And I will start by introducing the chairpersons of the session, Dr. Abdulaziz Al-Hamad. Abdulaziz is a consultant radiation oncologist and head division of radiation oncology at PSMMC, and he is the past director of the department. I'm his successor, actually. And with us also Dr. Walid Sloui. Walid is a senior consultant medical oncologist with a special interest in GU, gynae, and GI cancers. Will join us in a few minutes, Dr. Iman Bukhari. Dr. Iman Bukhari is a senior consultant palliative oncology palliative care, and she is head division of the palliative care at the oncology department at PSMMC. Without any further ado, I'll handle the mic to Dr. Abdulaziz Al-Hamad to start with the session. Abdulaziz, the floor is yours. Go ahead, please. Thank you, guys.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Islam, for this nice introduction. It's my pleasure to introduce my colleague and my friend, Dr. Fahad bin Shamsa, who's a consultant medical oncology, King Fahad Specialized Hospital, Dammam, and also the head of medical oncology section over there. He will give us a talk about immunotherapy and adjuvant therapy in renal cell carcinoma.
Thank you very much, Dr. Abdulaziz and Dr. Walid. And thanks to the organizing committee and scientific committee for inviting me to this very successful event. And I'll be talking to you for less than 20 minutes about the role of immune therapy in adjuvant setting in kidney cancer. We learned from before, the story started very early. We had several trials of TKIs in the adjuvant setting for RCC. They produced equivocal results. Some of them did not even show progression-free survival benefit, but we learned from them that probably there was some benefit, limited benefit, at least to the higher risk patients of RCC, and the risk category in those old trials was defined mainly on the T stage and the node status change. We know almost half of patients, they recur after nephrectomy, so that which express the unmet need for adjuvant treatment. So I'll be talking to you about this landmark study, adjuvant Pimprozumab after nephrectomy in renal cell carcinoma, published in New England Journal of Medicine, August 2021. So this is the Keynote 564, and I'll be talking to you about an updated analysis that was presented in the last GU ASCO, 30 months follow-up. A quick reminder about the study design. So clear cell renal cell carcinoma, at least intermediate to high risk. Also, they included some high risk and M1, no evidence of disease. Of course, after surgery, they had to be randomized within 12 weeks of surgery. Of course, no prior systemic treatment. Almost 1,000 patients were randomized to either Pimprozumab, 200 milligram every 3 weeks, up to 1 year for 17 cycles, or placebo. The primary endpoint is disease-free survival, and overall survival is a secondary endpoint. The study was presented before in the last ESMO, and it showed that the study was positive and met its primary endpoint, improvement in disease-free survival with a hazard ratio of 0.68. And that was very significant. Overall survival was not mature at that interim analysis. And I'll be talking to you about some updated efficacy points for this study. To start with, I will spend maybe a minute on the eligibility criteria, which is really very important in this study. So risk for recurrence was assessed in this study according to the either intermediate risk to high risk, and these patients are T2, but they have to be grade 4 or sarcomatoid differentiation, or any T3 will be intermediate to high risk. The high risk disease are T4 or any node positive disease, and M1 with no evidence of disease. So they had a metastatic deposit and it's been resected with no evidence of residual disease. So this is the baseline characteristics. And again, it's very, very important. You can see the median age 60, the usual things in clinical trial, but focus with me on the disease risk category. So intermediate to high risk were 86 or 87% of this study. So most patients in this study were in the lower risk group, let's say intermediate to high risk. So they had to be T2 with grade 4 or sarcomatoid, or T3. And we learned from Tract study of sunitinib and also bazopanib that if anything, the adjuvant benefit will be for the higher T3, at least in that TKI. But of course, we are in the immune therapy era now. The high risk is 8%, and M1, which is the highest risk, 6%. So very small number. So to me, when I read the study, this is probably the main challenge to the study to show benefit, because it doesn't really include that much of a significantly high risk. So this is the primary endpoint, disease-free survival. And despite that, 87% of patients in this study were intermediate to high risk only. The study was very positive and very clear separation of the disease-free survival curves, very nicely, clearly separated, with an absolute benefit in the disease recurrence of 11% favoring adjuvant Pimprozumab. Looking at the subgroup analysis, the benefit to delay disease recurrence was universal. So every subgroup and all subgroups got the benefit of delaying disease recurrence. So this is slides subgroups patients according to their risk. And again, the benefit, as you can see, is higher with the higher risk. And that's what we expect from adjuvant studies like in colon and breast. We always use the risk of recurrence to predict and estimate the benefit of adjuvant treatment. So you can see the median, the hazard ratio for disease-free survival is 0.68 for the intermediate high risk, 0.6 for the high risk, and for the M1, no evidence of disease, is very impressive, 0.28. Of course, small numbers, but that is really what you expect. So the benefit of adjuvant treatment goes up with the higher risks. The higher risk, the higher benefit of adjuvant treatment. And this applies also to the sarcomatoid features. This is the overall survival, and after 30 months follow-up, and we know in adjuvant studies, usually you can wait for several years, maybe 5 years, to see a real overall survival benefits. The initial plan for this study is to analyze overall survival after 200 overall survival events or deaths. And yet we had only 23 events in Pimpro arm and 43 events in placebo. You can see it's almost a double of events favoring adjuvant Pimprozumab, but yet that is not significant yet. And of course, it is premature. But we see a trend. So we had interim analysis, and now we have this 30 months follow-up, and we see a trend of improving overall survival hazard ratio, which has little bit improvement from 0.54 to 0.52. So regarding safety of Pimprozumab in the adjuvant setting, it's really what you expect, but it's very important because we always criticize adjuvant studies, and we want a benefit in quality of life and also cost and things. You don't want an adjuvant treatment and the commitment to this drug for 1 year to show a deterioration in quality of life. And I will show you a whole analysis about quality of life. But there was no surprises in this study. So grade 3 and 2-5 side effects, 32% in Pimpro, 17% in the placebo. And the immune-related grade 3 and 4 were 8% in Pimprozumab. This is the details of the side effects. So it's mostly what you expect: fatigue, pruritus, thyroid dysfunction, diarrhea, and rash. But they are hardly. Most of them are grade 1 and 2. So then we had the analysis about patient-reported outcomes for this Keynote 564, which you really want to see. And this is the trend in the newer studies. They always include quality of life assessment. So the dotted pink lines up and above and below are the cut line or the threshold for significance for change in quality of life. Different scores of quality of life, functional score, and disease-related symptoms, and quality of life. So different scores they used, and all of them, they show that there is no change in quality of life and no deterioration of quality of life caused by giving patients adjuvant Pimprozumab. So as you can see from these different scores, none of them really show any change in the quality of life. So there was no clinically meaningful differences in health-related quality of life or symptom scores consistently observed in the adjuvant for either Pimprozumab or placebo. So it's the immune therapy era, and it's not only this study. We will be seeing more studies in these settings, and this is one example, PROSPER RCC study, which recruited patients and put them to a perioperative Nivolumab around nephrectomy. So 1 cycle before nephrectomy, and then 9 doses after a nephrectomy, and we're waiting for this study. Probably it will be reported probably this year in the Esmo, or maybe maximum next year. at least interim analysis. So I'm coming to conclude. So the Keynote 564 study met its primary endpoint despite the challenge of having most of patients as intermediate high risk with a good hazard ratio, 0.63, and the benefit was consistent to all subgroups. Of course, the overall survival data are not mature yet. And I think this study also tells us about the improvement we had, maybe in the surgical techniques or selecting patients for treatment, because yet more than half of patients still did not recur after this study, 30 months. So, of course, we want to balance efficacy and safety, and maybe it's worth doing in the future studies to include patients really high risk group, and that study, I think it will show more obvious and clear benefit. Yet, this updated analysis of this Keynote study showed that adjuvant Pimprozumab is a new standard for patients with RCC at a significant risk of recurrence. And we had recently some debate with some of our colleagues, scientific debates to discuss this issue, because we still lack the overall survival data, which I understand totally. But I think at this point, adjuvant Pimprozumab should be considered post-nephrectomy, at least for the high risk disease. Thank you very much.
Thank you, Dr. Fahad, for excellent and elegant presentations, and we'll keep the questions at the end of this session. It is my pleasure to introduce Dr. Marwan Hajile. He is a senior consultant medical oncology. He is the head of oncology department at the King Abdulaziz University in Jeddah. He will talk about immunotherapy in bladder cancer. Please, Dr. Marwan.
Assalamu alaikum jami'an. Thank you, Dr. Walid, for the introduction. Thank you, Dr. Assam and Dr. Mirvat, for the invitation. And it's very hard to follow Dr. Fahad after his elegant presentation, but I will try my best and hope for the best as well. Okay, so my task today is about the use of immunotherapy in bladder cancer. This is my outlines, and let's just go. This is just to outline for you the basics actually of the basic old outcome for patients who are treating in the metastatic setting. And as you see, the median overall survival at best is around 15 months. In patients who are cisplatin eligible, the outcome is actually worse. And as you see here, the older data that we have, it showed that overall survival reaching 9 to 10 months at maximum. Then we have the discovery of multiple immunotherapy agents, as we all saw during this conference. So we'll start first with the metastatic setting disease and the combination of chemo with immunotherapy. We have the IMvigor 130, which is using atezolizumab on top of the chemotherapy. It included all patients with the metastatic disease, whether they use cisplatin or not. It had 3 arms, immuno plus chemo, immuno alone, and the chemotherapy alone arm. If you look down here, you will see that actually the required p-value for showing a positive study is very low, and it's 0.01 for PFS, and it's 0.095 actually for the overall survival. If you look here at the first outcome, which is the progression-free survival, it was actually positive is in the p-value, 8 months versus 6 months for the use of the combination of chemo with immunotherapy versus chemotherapy. If you look at the overall survival, it was negative based on the p-value. And if you look at the final median overall survival, it was 16 months for the addition of chemo and 13.4 months for using the chemo alone arm, which is not far from the standard data that we have for the standard treatment in the past. If we look at also the overall survival for the use of monoimmunotherapy, as you see, the curves are actually on top of each other, and there is actually a crossing at the middle at around 10 months. And if you see here, again, atezo monotherapy showed an overall survival of 15.7 months. And the chemotherapy arm showed the same overall survival that we saw earlier, which is around 13 months. However, this was not a positive outcome, but just to show you what you expect if you use immunotherapy as a monotherapy. This is the response rate, and it's comparable, 44% to 47% for chemo versus chemo plus immuno. And for the use of monoimmunotherapy is 23%. Similar study, but using Pimprozumab followed by maintenance is actually, they had the same population in all arms, the same population to the IMvigor 130. One arm had chemo plus immuno followed by maintenance immuno. The other arm was immunotherapy alone. And the third arm was the standard of care, which is chemotherapy. And they included patients who received carboplatin or cisplatin. Again, they had, because it's a 3-arm study, they consumed all their alpha, and they end up with the requirement p-value that is very low. For the overall survival, it was negative, as you see here. The two curves are on top of each other. Again, we're seeing a median overall survival, which is 17 months for the combination of chemo-immuno versus 14.3 months for chemotherapy alone, similar to what we saw in the IMvigor 130. And I think it's not that far from the older data that we have for the use of MVAC or GemCis. If you look at the PFS and the intention to treat population, very close. Actually, it was negative again, the p-value 0.033. For patients who ended up having the monotherapy Pimpro alone, we are seeing a similar curve to what we saw in the IMvigor 130, and the two curves are on top of each other. There is crossing at around 12 months. If you look at the median overall survival, it was 17 versus 14 in favor of the Pimpro. So again, it shows you that maybe statistically it's not significant difference between both, but however, it looks like Pimpro alone is a valid option for patients who cannot go into chemotherapy. But the study in general, it was a negative study. This is just to show you as a meta-analysis that looked into both study and came up with a final analysis. As you see here, the overall survival was in the middle, just not showing, not favoring any treatment, whether the standard chemotherapy or the combination. And basically, that's just what we saw in all the studies. So I think this approach altogether has failed to show a statistical significant difference. However, we learned that actually the use of monoimmunotherapy can be actually done in certain patients, and can be an approach for, especially for patients who are ineligible to the use of chemotherapy altogether. All right, how about the use of dual immunotherapy? This is an approach that was done. We have the Danube study for the use of Darvo plus Trema, and the use of versus the standard chemotherapy alone. This study was negative altogether, so I'm just not gonna go over it, but just to show you here, again, the same median overall survival was seen 14.4 months, 15.1 months in all, whether you use Darva alone or whether you use Darva plus Trema. What about platinum eligible patient? IMvigor 210 looked into that. It's a small study. However, it showed that all the treatment with the use of atezo and cisplatin eligible gave you a similar curve to what we see in patients who receive chemotherapy. We had some overall response rate. There are some variation based in the the PDL testing result or expression. However, it's a valid option for those patients as well. Similar to that, we have a single arm study for Pimprozumab monotherapy. Again, if you look here at the median overall survival, it was 11.3. It's less less than what we saw earlier. However, remember, those are patients that altogether were ineligible. So some of them might have other comorbidities that affected their altogether overall survival. What about the use of approach of maintenance IO after induction chemotherapy? We have the famous Javelin study. It looked into all patients, similar to what we see in Vigor 130. And all patients, they are treatment naive. They ended up with the induction chemotherapy of 4 to 6 cycles, whether cis plus gem or carbo plus gem, depending on the eligibility. After that, they had a free interval. And then afterward, they were randomized into maintenance Nivolumab versus best supportive care. The primary endpoint was overall survival. And if we look here, the overall survival, we have 21 versus 14 months. Just to remind you, this overall survival is calculated from the time of randomization, which was after the 3 or 4 months of induction chemotherapy. We're seeing here, as I said, 21 versus months versus 14 months, very significant p-value 0.001 and a hazard ratio of 0.69. Even the upper part of the hazard ratio is 0.86 in the confidence interval. Also, if we look at the PFS, we had 3.7 months compared to 2 months. Remember, just to remind you again, this was done after the induction chemotherapy phase. So it's calculated from the time of randomization. Again, it was significant based on the p-value. Another study that is just like initial study, and maybe we'll see it more in the future, is the use of Darva combined with olaparib after induction chemotherapy. For patients with high-risk disease. The primary endpoint in this study was the progression-free survival. And as you see here, actually, whether they use Darva or Darva plus olaparib, the two curves are on top of each other. We have a PFS of 4.2 compared to 3.5. And the p-value is not significant. So it was a negative study, and I think they did not plan it right. Maybe if you use an arm that has no treatment, maybe it will show better results. All right, what about second-line therapy in metastatic disease? We have the Keynote 045 looking at the use of mono Pimprozumab versus different kind of chemotherapy, investigator choice or physician choice. And we see here that there is a clear separation between the two curves, although there is a crossing at the beginning. And in terms of hazard ratio is 0.7 and very significant p-value. We have a median of 10 compared to 7 months. And just to remind you, this is in the second line setting, which is considered actually a good outcome. Most groups actually benefit from the use of immunotherapy compared to the chemotherapy. Another study actually for second line is the use of drug conjugate antibodies, sacituzumab govitecan, in a cohort plus Pimprozumab in patients who progress in initial treatment. Just to show you here, we had this is a phase 2 study, so it was looking into an overall response rate, and it showed a 34% response rate. More than 60% of the patient had some sort of response and shrinkage in their tumor. So it's a promising approach, and I think we will see more in the future. What about non-metastatic disease? In the adjuvant immunotherapy after surgery, we have the Checkmate 274 using adjuvant Nivolumab after surgery. Most of the patients in this study had some sort of induction or new adjuvant chemotherapy, but some did not have new adjuvant. Different kind of agent, whether cisplatin or carbo were used. The idea of the study is after surgery in those patients with high-risk disease to use Nivolumab for 1 year as an adjuvant treatment versus the placebo. The primary endpoint was DFS. Just to show you, this is just the patient's characteristics, and they included upper urothelial tumor, the renal pelvis and ureter as well. In terms of DFS and the intention to treat population, we had a hazard ratio of 0.7 with a significant p-value, although the two curves are very close to each other. And if you look here at 6 months and 12 months, we have 74% versus 60 and 62% versus 46% in terms of DFS. when you look at the patient with PDL positive more than 1%, you see more separation between the two curves. The hazard ratio come down to 0.55, and the p-value also is again 0.001. So in general, this also was a positive study. When we look at the, I'm sorry, this is a different study. Similar approach was done actually with the use of adjuvant atezolizumab in the IMvigor010. Again, for similar population. However, this study was negative. As you see here, the two curves are very close to each other. And in terms of median DFS, 19 compared to 16 months. Hazard ratio crossing the 1, and the p-value was 0.24. So two approaches, one with Nivo, as we see here, and one with atezo. The Nivo one was positive, the atezo was negative. This is just to show you, again, from the checkmate. The slide is repeated, and let's go. Yes. This is a summary of all the studies that were done in the adjuvant setting. And as you see, some of them are still actually recruiting. And however, the only positive study we have so far is the Checkmate 274 with the showing a positive effect in terms of using of adjuvant Nivo in high-risk disease. What about bladder preservation? This is still an experimental approach. We have one study, the Pimpro treatment of patients with high-risk non-muscle invasive disease, unresponsive to the BCG injection. It's just a single cohort study with the use of Pimprozumab. So most of the patients, they're not going for surgery, or they elected not to go for surgery. We're looking into the effect of the use of Pimprozumab after they failed the BCG injection. They don't have a muscle invasive disease, so they're not like candidate for chemotherapy, but usually those patients, they should go for surgery. However, they elected not to go for surgery. The primary endpoint is actually absence of high risk muscle invasive disease, or just no progression, basically disease control. If we look here, complete response, we have 40% complete response, which is actually an excellent result. And a lot of people actually also had some sort of partial response. Progression almost was none. None of them progressed. I think the median follow-up, if I'm not mistaken, I will show it later. And so yeah, median duration of complete response is around 16 months. So it's a promising approach. We still need just more data in that regard. And maybe it's going to be a possible option for our patient. I still believe in a surgical approach for this patient, but however, if they elected not to go for surgery, this is an option for them. Okay, in summary, in the first-line metastatic setting, we all know that chemotherapy is still playing a major factor. However, the best approach is to go for chemotherapy induction with whatever standard regimen you use, followed by Nivolumab as a maintenance treatment. That's actually the preferred regimen. There are other options for patients who are cisplatin ineligible and also who are not candidates even for carboplatin. You can use a different kind of immunotherapy. We have the atezo in PDL positive patient, and we have the Pimpro as an option based on the data that I just showed you. In the second line setting, if any patient did not receive immunotherapy in the beginning, they can actually receive any immunotherapy. Maybe the preferred regimen based on the NCCN guidelines will be the Pimpro, but other immunotherapy also showed some benefit. In terms of patient in the perioperative setting, still, if the patient is having a muscle invasive disease, they still should go for neoadjuvant chemotherapy as a preferred approach, or chemotherapy afterward as an adjuvant approach. We're still looking into the use of adjuvant Nivolumab as a patient with high-risk disease after surgery. And I think this approach is just going to go up in the ladder and maybe will become the standard of care very soon. So far, all other immunotherapy that were used in the perioperative setting did not show any benefit. I think the bladder preservation approach with the use of Pimpro as a single agent for patients who elected not to go for surgery also will grow in the future. This is my take-home message, is just exactly just what I just mentioned. In metastatic disease, I prefer the Nivolumab as a maintenance treatment after induction chemotherapy. In the earlier stage disease, I'm looking into the use of actually adjuvant Nivolumab for high risk patients. I don't think the bladder preservation approach is a preferred option for me in terms of using just immunotherapy for non-muscle invasive disease. I prefer the surgical approach. However, in patients who elected not to go for that, I would consider the use of single agent immunotherapy, Pimpro. With that, I conclude and thank you.
Thank you very much, Dr. Marwan, for this well comprehensive talk. Our next speaker is Dr. Thomas Powell. He's a professor of genitourinary cancer, and he's the Pratt Oncology Center and St. Bartholomew Hospital, United Kingdom. He will give us talk about the immunotherapy in metastatic renal cell carcinoma, the many options, how to choose. Dr. Thomas? I think he's muted.
I'm unmuted now, I hope.
Good.
Thank you very much for inviting me to talk today about first-line renal cancer. I'm going to pull up some slides right now, if I can get them open. Yes, I can. I hope you can see my slides. Thank you very much for inviting me today. I'm sorry I'm not with you, of course. I enjoyed the previous talk on urothelial cancer as well, and I hope this talk is going to be as good as that. I think that the frontline renal cancer space has a huge change over the last 5 years. And unlike bladder cancer, we now can expect patients to live for 5 years with the latest treatments that we have available to us. These are my disclosures. You'll be aware that we had
Dr. Thomas, I beg your pardon. The connection is not clear at your side.
IMMC prostate cancer.
Dr. Thomas, do you hear me?
Prognosticable intermediate.
Dr. Thomas? Excuse me? I think, Dr. Thomas, I think...
Let me see if I can...
I believe you had bad connection.
I will...
Could you please disconnect and connect again? Maybe this will be improved.
Can you hear me clearly?
Now we hear you very well, yes.
Okay, great. I'm not going to put my video on, if that's okay. And I'll put my video on at the end. And I hope that will work.
It's much better now.
Good. And can you see my slides?
Indeed, yes. But if you can...
Okay, let's see how we go. It might be without my video. I've got to say, you're not missing much by not being able to see me. So I've got the perfect face for radio, I'm told. So I'm going to talk today about frontline immune therapy in urothelial, in kidney cancer. It's a really exciting time. We've got new drugs, new combinations. And today I'm going to explain to you how you can pick between them. I have a number of disclosures. the first line space, the metastatic space in the first line setting is defined by the IMDC criteria. These criteria split patients into favorable, intermediate, and poor risk disease. These criteria are largely based around blood tests, a single blood test, hemoglobin, neutrophils, platelets, maybe the calcium, performance status, and the time since diagnosis. These criteria are not proper biomarkers. It's not a selection based off biology of disease. The issue is it's a selection based off the aggressiveness of the disease. And the more aggressive disease has more aggressive.
I'm sorry again, Dr. Thomas, again, the same problem. Dr. Thomas. Can I ask you to disconnect and connect again? Maybe that will solve the problem. Dr. Thomas? Dr. Thomas? Excuse me, Dr. Thomas. We are unable to hear you, so if you please disconnect and connect again.
Is that any better?
Yes.
Okay, good. Let's see how we get on this time. I apologize. I've stopped my video. I'm going to share my screen. Okay. I was just talking about the good and intermediate and poor risk groups. And what I had said was that the good risk groups are represented mainly by angiogenic signatures, whereas the poor risk groups are represented mainly by immune and proliferative signatures. The problem that we have is that we are currently in the good and intermediate and poor risk, all of the groups are represented. We need to move to a biomarker era in kidney cancer where we are selecting patients based off the biomarker, and we're not currently doing that. So let's go to the first study, and this is the Ipilimumab and Nivolumab trial. Ipilimumab and Nivolumab is licensed in intermediate and poor risk disease. It's a PD-L1 and a CTLA-4 inhibitor. Essentially, in the latest update, with 5 years of follow-up, we can see two things. Firstly, we can see a significant improvement associated with Ipi-Nivo. And secondly, we can show clear separation of the curves from a progression-free survival perspective. What this essentially means is Ipi-Nivo is associated with longer durable remissions. It's really good at getting long-term control of disease. The problem with Ipi-Nivo is the response rate is quite modest. It's not that terrific at getting control of disease. And so essentially what happens is we give Ipi-Nivo and some patients will progress. Nevertheless, the CTLA-4 looks important at long-term disease control. There's also a discussion about the favorable risk patients. The drug combination seems to work less well in this combination. As I showed you on the previous two slides, in good risk patients, VEGF targeted therapy, the angiogenic signatures do seem important. As I said before, why don't we look for angiogenic signatures rather than using this surrogate IMDC biomarker? Nevertheless, as it currently stands, the drug doesn't look so good in good risk patients. So we move across from Ipi/Nivo, which was practice changing. It has a significant survival benefit over sunitinib in intermediate and poor risk patients, to the Keynote 426 trial. The Keynote 426 trial showed initially in the first interim analysis a hazard ratio for survival for pembrolizumab and axitinib of 0.53. This is a significant reduction in the risk of death and is an impressive reduction in the risk of death. It also hit a progression-free advantage and also a higher response rates. Response rates were 60% versus 35%. At this time, Axi-Pembro looked superior to Ipi/Nivo because it hit PFS, response, and overall survival, and the overall survival hazard ratio was better. And while the PFS has been maintained, you will see the overall survival signal has drifted downwards and is currently at 0.73. I think it will stay at 0.73 now. Actually, if you look at the all-comer population with Ipi/Nivo, you can also see a hazard ratio of about the same, 0.70. So all of these regimes I'm going to describe to you today have almost identical overall survival advantage. I then move to Cabo/Nivo. Some people say to me, why have we repeated the same experiment again? Because it is very similar. Cabo, very similar to Axi, Nivo, very similar to Pembro. And guess what? It shows an almost identical result. It's got a PFS advantage, a response rate advantage, but also a hazard ratio for survival of 0.70. And then finally, I come to the Len-Pen trial, lenvatinib and pembrolizumab in combination versus sunitinib. And guess what? From a survival, there's a progression-free survival advantage. This progression-free survival advantage has a hazard ratio of 0.39. This is the lowest data we've seen for any of these combinations. In reality, this is impressive data because of this low hazard ratio. Nevertheless, when we move to overall survival, we get the 0.72. And so what I've described to you so far is 4 regimes, 3 of which look almost identical: Cabo/Nivo, Axi-Pembro, and Len-Pen. Ipi/Nivo seems less good at getting initial control of disease. So overall, one can pick any one of these 4 regimes and they're entirely justified. Some people say, does quality of life differentiate between the 4 regimes? I think it's fair to say that Ipi/Nivo, because you don't have chronic VEGF TKI use, is likely to have the best quality of life data. The other 3 regimes are quite difficult because they've used different tools to assess quality of life, and therefore the results are also different from each other. So here is, for example, is the Axi-Pembro data, and this is not significantly better for Axi-Pembro. You can see sunitinib going up and down like a yo-yo. That's because sunitinib is an intermittent therapy, and Axi-Pembro being somewhere between the 2, and none of them being clinically important differences. Essentially, this is also true for the other regimes, although Cabo/Nivo does seem to have better quality of life data. So outcomes in the ITT population, the hazard ratios of 0.72, 0.73, 0.70, and 0.72 are almost identical. All 4 regimes give you a similar survival benefit. Ipi/Nivo is attractive because it appears to be associated with long-term remission and good quality of life. Keynote 426, Axi-Pembro is attractive because it's the lowest hazard ratio we ever had, and axitinib is quite an easy drug to give because it has a short half-life. Cabo-Nivo is attractive because it has positive quality of life data, and Len-Pen is attractive because it has the lowest PFS and highest response rate. So you can make an argument for giving patients any of these four regimes, and it's difficult to be critical. There is a big debate in the favorable risk population. The more mature data suggests even the VEGF-TKI IO combinations, Axi-Pembro, Len-Pen, Cabo-Nivo, are struggling to beat sunitinib. In our guidelines committee, we still think the CR rate is higher, the response is better, and the PFS is better. So we still recommend giving VEGF-TKI and IO therapy in good risk patients. But it's very hard to be critical of those clinicians who want to treat favorable risk patients with single agent sunitinib or pazopanib based on the data available to us. And here are the Esmo guidelines. They're relatively straightforward. In the favorable risk patients, VEGF-TKI IO, in the knowledge that sunitinib is an alternative, and any of the four regimes in intermediate and poor risk disease. Many people ask me, what would we treat in second line? And actually, I just say, give any regime you've not given before. The data is very weak in this setting. So let me take you to a sequencing world where we give VEGF-TKI and PD-1 therapy first. It's reasonable to select this for all patients. What I say to my clinicians who I work with is pick one and use it well. Axi-Pembro is a perfectly good combination. But what do we give next? And the answer is, we don't know the answer. But what I can tell you is it looks like VEGF targeted therapy is better than mTOR therapy. So continue, in my opinion, with a drug you've not given before. So Cabo-Nivo, give axitinib next. Len-Pen, Cabo next. Axi-Pembro, Cabo next. Quite simple, actually. Cabozantinib has got a survival advantage over everolimus, but remember, axitinib was tested against sorafenib. Axitinib beats sorafenib from a PFS perspective, but not from overall survival. But there's a difference between sorafenib and everolimus. So it's not right to say cabozantinib is better than axitinib. As far as we know, all the VEGF-TKIs are creating similar responses, or certainly the well-used ones of sunitinib, axitinib, and of course cabozantinib and lenvatinib. There's very little data to support subsequent therapy post first-line therapy. The classic studies, the randomized trials, do not exist. We have some single-arm trials showing modest results. The reality is, if the patient's cancer progresses on first-line therapy, subsequent therapies are less active and not curative as things currently stand. Many people say to me, what about lenvatinib and everolimus? There was a lenvatinib and everolimus arm in the CLEAR trial in the frontline setting. It didn't perform particularly well. From a survival perspective, it was no better than sunitinib alone, and therefore it shouldn't be recommended as a regime above other regimes. It's probably equally active. The data that supports its use is based off a randomized phase 2 trial. But you can see here the numbers of only 40 patients are small, and the benefit versus lenvatinib is not clear, and certainly there doesn't appear to be a significant survival advantage. So what can I tell you so far? In the frontline setting, pick one regime and use it well, get used to it, because that is the most important issue, because there are more similarities than differences. If the treatment is to fail, second-line regimes can be based around a VEGF-TKI that have not been given previously. So, reasonable questions, Does mTOR have a role? We don't know. Does mTOR add activity to VEGF TKI? I'm not sure. And does VEGF targeted therapy work after immune therapy? And the answer is a bit. So very simple. PD-L1 based combinations first, VEGF TKI sequenced second. Should we continue with immune therapy? Should we continue with atezolizumab or continue with nivolumab after progression? Currently, the answer is no. There is no evidence for continuing immune therapy. The trials are ongoing, but once patients' cancers has progressed on immune therapy, there's no current role for subsequent immune therapy. And what about this last biomarker issue? Well, renal cancer patients are very gray, I'm afraid. We do not have a colorful biomarker world. In the other cancers I treat, huge efforts are being made, but we're not doing that in kidney cancer. But in kidney cancer, we do know that biomarkers exist. We do know we can pick angiogenic signatures, and we do know there are proliferative signatures as well. We need to start doing these sorts of trials because that's the only way we're going to make it, I think, to the next step. Isn't it a shame, as it currently stands, when we start kidney cancer, we give a patient a treatment, they start a predictable escalator, and that never changes. We know exactly what we're going to give second line, we know exactly what we're going to give third line, but this graph on the right shows us the cancer is changing. So while the patients may be on a two-dimensional escalator, the cancer is in a three-dimensional world changing. We need to be doing personalized therapy in this cancer fairly soon. Here are the guidelines that we're currently using, first line, second line, and third line. I've described them already to you. Pick one and use it well. What I'd like to say in summary is I'm sorry the IT didn't work very well, number one. Number two is kidney cancer is reaching a plateau. We've recently seen some COSMIC 313 data, Cabo, Ipi-Nivo, that did not look fantastic at this point. The likelihood is we're going to be using PD-1, VEGF combinations, or Ipi-Nivo for the foreseeable future. And therefore, we need to learn how to give these drugs optimally. Many thanks for your attention. And I'm very happy to answer any questions.
Thank you very much, Dr. Thomas. Now I will leave the mic to my colleague, Dr. Walid, to run the question and discussion with all the speakers.
Yeah, please, Dr. Fahad and Dr. Marwan, if you can come to the stage. Any polling questions? Thank you for excellent questions, for excellent talk presentations by 3 speakers. If there is no questions, I will start with my questions to Dr. Fahad. The first question, Dr. Fahad, you mentioned about the adjuvant role in the renal cell carcinoma. That, as you mentioned, the new concept of the adjuvant, and as we know that TKI in the adjuvant setting, and now we are talking, as you present, the immunotherapy in renal cell carcinoma. How is that in practice now? Are you confident to say is standard of care, practice change in the renal cell carcinoma as adjuvant, and for whom patients?
Thank you very much, Dr. Walid, for this question. And confidence needs overall survival benefit, really. But I think the trial is very well designed. Like the usual adjuvant studies, they need definitely more follow-up to show overall survival benefit. I showed you in the 30 months follow-up some trends towards the benefit of overall survival and improvement in the DFS benefit. So I would expect with more time of follow-up, we will see probably overall survival benefit, but that will need a follow-up of let's say several years, at least 4 or 5 years probably. At this time, I think adjuvant RCC is unmet need, especially for those high or highest risk patients, especially those with M1 and with no evidence of disease, or the very high risk patients. I think we should consider Pimprozumab, and this is what we expect. Like the immune therapies now is very efficacious in the metastatic setting, and I think we should be considered for the high risk patients.
Thomas, you can add anything, Thomas?
Well, I'd like to start by saying I thought it was a fantastic talk. It summarized the topic very well. I think there is one consideration that we need to make, and that is that we are not clear about what the other trials will show. One of the questions which many people ask me is what happens if the Atezolizumab trial and the Nivolumab trials are negative? If these trials are negative, will this mean that will it have a negative impact on the Pembrolizumab data, or do we think there's something special about Pembrolizumab? So I think that's absolutely right what was said. I think that as it currently stands, it's an attractive treatment, but without survival, we don't have confidence in it. We will have to wait for years to be confident. In the meantime, there must be a nervousness if the other trials come home and negative. Now, clearly, if the other trials are positive, it's easy. Everything's going in the right direction. But my experience is kidney cancer is never easy.
Thank you. Dr. Marwan, you mentioned about bladder cancer now for those patients who is ineligible as one of criteria to immunotherapy. What about patients is doing the immunotherapy, chemotherapy, and there is a maintenance as a guidelines is the preferred regimen? What about the Nivolumab as maintenance?
Yeah, so I think we had so many data in the use of immunotherapy in bladder cancer, especially in the advanced settings, and we saw some responses earlier and some favorable results, and that's why it came to the earlier stage as well as the first-line setting. All the trial design are complicated and so on, except I think for the Nivolumab study, it was an interesting study, the way they designed it. And I think they hit the right button in there when from the time of randomization and how long they use the drug. In terms of outcomes and based on the study design, it's a very positive study, no question about it. Yes, I think it's a new standard of care. Whether just we should use it for every patient or not, that will be a question because of the cost problem. That's the only caveat in the use of immunotherapy in this setting with the maintenance approach. However, statistically, and I think clinically, all the results are meaningful.
Dr. Marwan, another question about, you mentioned about the bladder preservation, especially for carcinoma in situ. Don't you agree with me this kind of exaggerated option and will make a lot of burden in the health system for early stage cancer to be treated for immunotherapy while there is another
recording in progress.
Exactly.
Recording in progress.
I think you hit the point there. This is a very important thing. And that's why in my conclusion, I think it's preferable to go with the standard option rather than using a very expensive medication for a long time without a clear outcome that we look at. Most of what they looked at actually is PFS, so we don't know even if there is a survival benefit. I would go with the standard approach, but as I said earlier, maybe I use the term bladder preservation in the wrong setting here, but I think just patient sometimes push you toward certain approaches and try to avoid surgery and morbidity, which is the right, but I don't know at what cost. And where as a clinician, as a society, how much are we willing to pay for such an approach? I think that will be another question. which is more important than whether this is working or not.
Thank you. If you allow me, Mr. Chairman, to ask Dr. Powell. So Dr. Powell, we have the IO, dual IO for metastatic RCC, and also we have the IO TKI combination. And both of them, both regimens are available. We use both of them. We try always to differentiate and select patients and to learn more. So my question to you about treatment selection, if your patients will have, let's say, symptomatic disease, high burden disease, does this have any impact on towards selecting dual IO or TKI IO?
This is such an important question. The key to it is we are being asked to differentiate between these regimes because, you know, the pharmaceutical industry wants us to, and I understand why they want us to, because they are passionate about their drugs and they've got great regimes, and all of them have great regimes. The reality is that cabozantinib is not better in bone disease, and that the quality of life of Axi-Pembro is going to be the same as Len-Pen in reality. So the harder we try to differentiate between these regimes, particularly the VEGF-TKI-IO regimes, that I think the more it becomes a hypothetical discussion. Let me tell you what the really important things are. The first is Ipi-Nivo is not good at getting control of disease for a lot of patients. So if you really want to get control, do not give Ipi-Nivo. You will lose control in some patients. Number one. Number two, if you want to get in control, the VEGF-TKI IOs are all probably the same, but Len-Pen has the highest response rate. It's 73%. It seems high. So it's reasonable to say, you know, that regime does seem to have the highest response rate. Having said that, the other regimes are equally good at getting control. The most important thing is that when you get into trouble with these regimes, which we do, with adverse events in the first 2 cycles, it's managing the adverse events to make sure you don't have to stop the therapy altogether. So if you said to me, what is the most important thing? It's about managing the adverse events, the patients having good support, having someone they can phone when things go wrong, managing the immune toxicity, restarting the TKI on time. All of those factors are much more important than the differences between Axi-Pembro and Cabo-Nivo. So it comes back to that point of pick one, get experience with it and use it well. I just said Len-Pen had the higher response rate. Axi has a really short half-life. So if you stop Axi, the side effects go away really quickly. And so that's actually really attractive. So you might say, listen, I want to be able to manage the toxicity really well. I'm going to use Axi-Pembro because I think that's the best way of doing it. And I'm totally relaxed about that. But you might come back and say, well, listen, I'm using Len-Pen. I'm experienced with it. I like using Len-Pen. I know how to do it. I'm going to continue to do that. And that is the right answer. There is no right answer to this question. The right answer is about good doctoring, good teamwork, and experience.
Thank you, Dr. Thomas. By this, we can conclude this excellent, wonderful sessions of urology, uro-oncology, and this is the part of finishing. Thank you to all speakers and moderators. And now we are invite Dr. Assam Murshid to present the satellite symposium. Thank you.
Hi, guys. We are still in the afternoon, isn't it? Okay, good afternoon. And it seems to be good morning somewhere else, but we're not sure. Anyhow, thank you very much for staying. And now we'll proceed with the last 2 satellite symposiums. The first one, which will be presented by Professor Robert Johnson, Jones, sorry. Sound? Hello? Hello? You heard what I said before, or just I have to start again? Okay, let's start again. Good afternoon, good day, and good night at the same time. Thank you very much for staying late here in the afternoon on a Saturday. And we'll proceed with the last and the final two satellite symposias, which will be carried out simultaneously. The first one, which is supported by Merck and Pfizer, which is the Advanced Urothelial Management, When and How. This will be presented by Professor Robert Jones. Professor Jones is a medical oncologist and professor of clinical research at the University of Glasgow, with, of course, a special interest of GU cancers. Professor Jones, the mic is yours.
Thank you very much. I will just try and share my screen, but thank you for the kind introduction. And thank you for giving me the opportunity to speak to you today. One moment. Okay. I assume someone will interject if you can't see my slides. Oops, it'd be helpful if I started at the beginning. So I've been asked to speak about maintenance immunotherapy in advanced urothelial cancer. As you know, I'm a medical oncologist in Glasgow in the UK, and I specialize in the treatment of cancers of the bladder, prostate, and kidney. These are my disclosures. And of course, when we're talking about advanced urothelial cancer, we're talking about essentially transitional cell carcinomas arising from the bladder, by and large, but about 20% of these cancers, of course, arise from the upper tracts, that's the renal, pelvis, ureter, and a very small number arising from the urethra. So how do we, in purely practical clinical terms, how do we currently subclassify patients with advanced urothelial cancer? Well, I guess probably still the main way in which we subclassify patients is according to their suitability for cisplatin-based chemotherapy. Cisplatin-based chemotherapy still being the mainstay of treatment for, or the optimal treatment, if you like, for advanced disease. And we have some well-established criteria. Here they are listed. I won't read through them. By and large, of course, it's the renal function which dictates whether a patient is suitable for cisplatin or not. There's, I think, a little bit of flexibility on the exact level of the GFR cutoff, and people use different schedules to try and overcome this. But fundamentally, poor renal function is the main reason why patients are not suitable for cisplatin. There is, of course, the growing concept of platinum ineligibility, and I'm sure your practices are no different from mine, and that there are definitely patients who are not suitable for cisplatin, but they're not suitable for carboplatin either. I think a lot of these patients, it's debatable whether they're suitable for any treatment at all, because these are often elderly, frail, highly comorbid patients. And there is no, to my knowledge at least, there's no globally accepted definition of platinum ineligibility. And we mustn't confuse cisplatin ineligibility with platinum ineligibility. In my practice experience, it's about a three-way split, with a third of patients suitable for cisplatin, a third of patients suitable for chemotherapy, but not cisplatin, i.e. carboplatin, and a third of patients who, by and large, end up not being suitable for any treatment at all for one reason or another. And then, of course, the other way in which we subclassify patients is by their PD-L1 status. I'm not going to into great detail on this, but we all know it's quite complex. Depends which assay you're using, depends which drug you're proposing to use. It's currently only really relevant in terms of in terms of treatment decision making, it's only really relevant in the cisplatinum ineligible population, because it defines a subgroup of patients who may be suitable for first-line immunotherapy with atezolizumab or pembrolizumab. As I say, subject to the appropriate test platform. So let's just have a little historical look at cisplatinum. As I've already said, I think chemotherapy still remains the mainstay first-line treatment for many patients with advanced urothelial cancer, regardless of whether you have access to other drugs or not. So a little bit of a historical perspective, and it's important to look at some of the dates here. So this is 1992, 30 years ago now, which was the first time that a trial demonstrated survival benefit with chemotherapy, and this was the MVAC combination compared with cisplatinum alone. Notice the poor median overall survival in the control arm here, but we're looking at a 4.5-month survival increment with combination chemotherapy. But those of you who've used MVAC will know and recall that it's quite a toxic regimen. And so then in 2000, we saw the publication of the Fonda-Maza trial, which was a trial to compare gemcitabine cisplatinum with MVAC. It failed to show superiority, but what it did show was that survival outcomes were very similar for GemCis as for MVAC. And of course, the tolerability profile appeared to be much better. And hence GemCis combination has really become the global standard of care for those patients suitable for it on the basis of this trial. And of course, with that group of patients unsuitable for cisplatinum, the standard of care has largely become gemcitabine plus carboplatin. And this was the EORTC trial of Maria DeSantis, which compared two carboplatin-based regimens and fundamentally showed quite significant activity for carboplatin gemcitabine, with a response rate there of 41%. Maybe no surprises that the median survival outcome in this group of patients unfortunately remains poor, but of course that's largely down to the poor prognosis of the patients due to the disease rather than purely due to the inactivity of the treatment. So let's move on and talk a little bit about immunotherapy. So I'm not going to go into great detail about this. This is really to explore further this role for immunotherapy as a first-line treatment. And so remember that initial product registrations were based on uncontrolled, non-randomized phase 2 trials. And then during the course of the randomized phase 3 trials, which of course were randomizing against platinum-based chemotherapy, it became clear that immunotherapy was not the superior option, at least for all patients. So this is the phase 3 trial of atezolizumab versus platinum-based chemotherapy. Remember, of course, there was also a combination arm of chemotherapy plus immunotherapy, but I'm just focusing on this first-line monoagent immunotherapy question here. And you can see on the left here, in the intention to treat population, there's really no benefit. This is for patients unsuitable for cisplatinum who received carboplatin in this trial. And you can see there's no real benefit over chemotherapy from the monoagent immunotherapy. But nonetheless, in the high PD-L1 group, note the relatively small numbers of patients now in this randomization, that it does look as though there is some superiority for atezolizumab compared with platinum-based chemotherapy. This is in the cisplatinum ineligible group. The pembrolizumab story runs a similar vein, although the outcome is slightly different. Again, there was a similarly designed randomized phase 3 trial, and this is now looking at the subgroup of patients who received carboplatin. It's not quite the same thing as the cisplatinum unsuitable, and you can again see in the whole population there's really no significant survival benefit for pembrolizumab compared with chemotherapy. But in this case, again, using a different cut point and a different assay for PD-L1 status, the PD-L1 high group of patients, again, doesn't look as though there's the benefit is retained in this particular trial. And this led to the US product label in this indication, this first-line cisplatinum unsuitable population, to be withdrawn. Now, of course, we've got to remember in both of these trials, you had to be platinum suitable because all patients in the control arm had to receive either carboplatin or cisplatinum. And so it doesn't answer the question in that putative population of patients who are completely platinum unsuitable. And I think for that group of patients, possibly there may still be a role for first-line immunotherapy. In the second-line setting, of course, we have good data for pembrolizumab in a randomized phase 3 trial. I won't go over the details of the design, but this is patients who had prior platinum-based chemotherapy and had then progressed. And these patients were randomized to receive either monoagent pembrolizumab or a dealer's choice of taxane-based chemotherapy or vinflunine where it was available. And this shows a clear and sustained survival benefit for patients receiving pembrolizumab. And this really set a standard of care, in my view, in the second-line setting. And so if we were to look at treatment pathways up until 2021, i.e. the point at which I've shown you the data, the cisplatinum suitable patients, the standard of care would then be cisplatinum plus gemcitabine, followed by a period of watchful waiting, but on the almost inevitable expectation that the patient would then progress, at which point pembrolizumab looks like the best treatment option. For those patients unsuitable for cisplatinum, then carboplatin gemcitabine was by and large the treatment of choice, again followed by pembrolizumab on progression, with a potential alternative option of going straight to immunotherapy for patients who are PD-L1 high. And for that group of patients who are totally unsuitable for platinum-based chemotherapy, then there would be a consideration for monoagent immunotherapy alone, presumably then followed by supportive care or a reconsideration of chemotherapy suitability. So that's the treatment pathway up until 2021. But then the concept of maintenance therapy comes into play here. And so we know that urothelial cancer is a relatively chemosensitive disease. The majority of patients get clinical benefit, not all of them responding, but the majority getting some clinical benefit. But we also know that, unfortunately, for the great majority of patients, the disease progresses relatively quickly, usually within a matter of months after completing first-line chemotherapy. And so there was an argument that actually we may be better giving immunotherapy at this point immediately after completion of chemotherapy rather than waiting for the disease to progress. In the interest of time, I'm not going to go through all of these arguments, but there's a number of rationales as to why maintenance immunotherapy, that is giving immunotherapy before the disease progresses, may be a more effective treatment than waiting for disease progression and then treating. Of course, the concept of maintenance therapy is not new. It's new to us in neurological oncology, but it's been widely practiced in other cancer types for some time. And these are some data for maintenance on the left, for maintenance durvalumab in patients with advanced stage 3 non-small cell lung cancer, and maybe slightly more analogously in ovarian cancer for patients with BRCA mutations, the use of olaparib following platinum-based chemotherapy, where this concept of giving maintenance therapy after completion of first-line chemotherapy in the absence of progression has become a standard of care. And so this led to the Javelin 100 trial, which was in patients with advanced urothelial cancer. So they kind of had either cisplatinum or carboplatinum, and a minimum of 4 cycles, a maximum of 6 cycles. And then within 4 to 10 weeks of their last dose of chemotherapy, the patients were randomized to receive either avelumab, which is a PD-L1 targeted antibody, or best supportive care. It's worth noting that the scheduling with avelumab is a 2-weekly infusion. And they continued with the infusions until unacceptable toxicity, disease progression, or withdrawal of treatment. And the co-primary endpoints are overall survival in the overall population and in the PD-L1 positive population. These are the characteristics of the populations. A slightly younger population than my practice. It's worth noting the PD-L1 positive population. It's about 50% of patients are PD-L1 positive and about 40% known to be negative, with an unknown group in between. And similarly, it's worth noting that although the majority of patients had cisplatin as a first line, actually it was a significant minority of patients who had received carboplatin as their first line treatment. But with a majority of these patients having had a partial or complete response, which this may look at atypically high at first glance, but of course it's not, because the patients who progressed were not eligible for the trial. And so these are the updated overall survival results. This is all randomized patients. This is the most recent analysis. And here you can see that there is the hazard ratio for death is 0.76 in the whole population. That translates through to an 8.8 month survival gain at the median for the patients receiving avelumab compared with those receiving supportive care alone. If we look at the subgroup of patients, remember this was a pre-planned primary analysis, the PD-L1 positive population. Maybe no surprises, the study remains similarly positive in this subgroup of patients with a hazard ratio of 0.69. And here we're seeing a slightly larger survival gain at the median. This is very small. For those of you who can see it, this is essentially the subgroup analyses, and there are no significant outliers. Maybe draw your eyes to the PD-L1 status group here, and you can see that if we look at the hazard ratios, if we look at the forest plots here, there's clearly no major difference between these two populations. What about that choice of first-line treatment? Because we all acknowledge that patients who are not suitable for cisplatin are generally associated with a poorer prognosis. But it looks like whilst that holds true, the actual magnitude of benefit from maintenance immunotherapy is very similar, and certainly you wouldn't wish to deny a patient access to a maintenance avelumab on the basis of them not having had cisplatin as a first-line treatment option. If we look at some of the key secondary endpoints, this is progression-free survival. And I think this is an important point to note, particularly if you're using this treatment for the first time, as of course that, as with all other contexts in urothelial cancer, immunotherapy does not work for all patients. And you'll note here that actually, unfortunately, that the majority of patients are progressing within the first 6 months, even in the treatment arm. But of course, we already knew that the risk of progression after chemotherapy in this population is extremely high and generally very rapid. But again, a clear separation in these curves in favor of the maintenance immunotherapy. What about subsequent therapies? So by and large, patients who had, if you draw your eyes to the columns on the right here, this is the subgroup of patients who had discontinued therapy due to progressive disease. And you can see that the majority of those patients had received some form of treatment. That's 3/4 of the patients in the best supportive care arm. And of those patients, the majority received immunotherapy as their next line of treatment. And so it does seem that patients were accessing immunotherapy, in the control arm, patients were accessing immunotherapy in subsequent lines, albeit not all of them did so. If we look at treatment emergent adverse events, I won't dwell on this. It's a very similar profile to what we're seeing with other immunotherapy drugs of this class. Again, with the expected immune-related adverse events being the dominant observed issues. If we look at these in a little bit more detail, again, we're seeing similar spread and similar frequency of events as seen with other immunotherapies, but relatively few high-grade immune-related adverse events. Quality of life. So this is largely driven by the period during the period of the progression-free period. And if we look at the bladder-specific scale on the left and the EQ5D, which of course isn't even a cancer-specific scale on the right, we're seeing very similar quality of life between those patients receiving avelumab and those patients receiving best supportive care alone. So it doesn't look as though the maintenance of avelumab is significantly impacting on patients' quality of life during the treatment period. So where does this leave us in terms of modern treatment pathways now? This is a cartoon I borrowed off Richard Thomas. So I think that for this group of patients who are eligible for platinum, the ones who are eligible for cisplatinum, the first-line standard of care remains cisplatinum gemcitabine, or you could justify using MVAC. And for those who are suitable for platinum but not cisplatinum, the standard of care in my practice now is carboplatin gemcitabine. And for those who are still benefiting after 4 to 6 cycles, they should then receive maintenance avelumab therapy. This poorly defined group of patients who are considered totally platinum ineligible, these patients, if they are PD-L1 positive, I think there's a strong case to be made for considering immunotherapy monotherapy, but it's not clear what the role of immunotherapy is in the PD-L1 negative subpopulation here. And of course, I think we have to be very concerned as to whether these patients who are genuinely unsuitable for carboplatin, whether they are really genuinely suitable for any treatment at all. So I'm just going to finish by just a very brief presentation from my own personal clinical experience. This is a very typical patient. He's comorbid. He's had a previous esophagectomy, had a previous aortic valve replacement, and he's a well-controlled type 2 diabetic. He had a past history of non-muscle invasive bladder cancer, for which he eventually underwent a cystectomy and was found to have T3 disease at cystectomy. He was assessed not by myself, he was assessed at the time as being unsuitable for adjuvant chemotherapy at that time. However, he did relapse. He's had this anterior abdominal wall metastasis, which was biopsy-proven relapse a year later. But he also had quite extensive, relatively low volume lymph node metastases, paraortic lymph node metastases. I deemed he was suitable for platinum-based chemotherapy by this point. And so he received 6 cycles of gemcitabine carboplatin, completing in September of 2020. And he had a very good, in fact, radiographically, he had a complete response to treatment. And you can see that lesion in the anterior abdominal walls completely disappeared. The lymph node you may not have been persuaded by originally has also resolved to sub-centimeter dimensions. So he's had a complete response radiologically to first-line treatment. At this point, maintenance of avelumab became available where I was working, and so he started that in November 2020. Note the dosing is slightly different from that in the trial. It's a fixed dose of 800 milligrams fortnightly. Indeed, his treatment is still ongoing, and he has a maintained complete response now 18 months after starting treatment in a patient who was significantly comorbid, but had nonetheless received first-line platinum-based chemotherapy. These are just the first 8 patients that I've treated outside of trials in my practice. So these are very immature data because the treatment hasn't been available all that long. The patient I've just shown you is, maybe not surprisingly, the patient at the top there. You can see that 3 out of these 8 patients have progressed, and indeed they've subsequently died from their disease in all cases. But the 5 of these patients, the treatment is still ongoing with a median follow-up of 44 weeks. So my take on my own personal experience here is that my experience is very much in line with what was seen in the Javelin 100 trial. So I'm going to just briefly talk about second line subsequent treatments. So this is enfortumab vedotin, which is an antibody drug conjugate, and this is an antibody which binds Nectin-4, which is highly expressed on the cell surface of most urothelial cancers, and that's bound to monomethyl orostatin E, which is a cytotoxic prodrug. And this drug is internalized into the cancer cell. So the antibody locks it to the Nectin-4. The Nectin-4 is really just acting as a lock for the key in this situation. The drug then gets internalized, and the cytotoxic is released and activated in the cytoplasm, and thereby delivers its cytotoxic kill selectively to the cancer drug, to the cancer cells. This has been the subject of a randomized phase 3 trial in advanced urothelial cancer, in which patients were randomized between, the patients had to have received both platinum-based chemotherapy and immunotherapy in any context, but it would include patients who've had maintenance immunotherapy, and they were randomly allocated to enfortumab vedotin or that same dealer's choice of taxane or vinflunine chemotherapy, with a primary endpoint of overall survival. And these are the primary results here, showing an overall survival benefit with a clinically significant risk reduction of 30%, which equates through to a near 4-month survival benefit at the median. There are other drugs coming along. Sacituzumab govitecan is another antibody drug conjugate, but targeting a different cell surface protein, also with a different cytotoxic payload. And these are phase 2 data, again, in that same population of patients who've had prior chemotherapy, platinum-based chemotherapy and immunotherapy. So again, we're seeing high response rates, with the majority of patients getting some degree of cytoreduction. And this is the subject of an ongoing randomized phase 3 trial, similar to the one I've just described. And of course, erdafitinib is also on its way. Currently, it is licensed in the United States. This is a fibroblast growth factor receptor targeted tyrosine kinase inhibitor. It's an oral drug, but it's only suitable for patients who have an activating aberration, genetic aberration in fibroblast growth factor receptor, which is about 25% of advanced urothelial cancers. Again, these are phase 2 data, but you're seeing the majority of these patients, again, getting some degree of cytoreduction with erdafitinib. And again, this is still the subject of an ongoing randomized phase 3 trial. So in summary, patients suitable for platinum, whether that's cisplatin or carboplatin, for these patients, the best survival outcomes appear to be associated with chemotherapy, followed by maintenance of Nivolumab for those who have clinical benefit. This appears to be true of patients both suitable and suitable for cisplatinum. The role of first-line immunotherapy, in my view, in the platinum-suitable population is now uncertain, although I think it's fair to say it remains an option, but I think it's not clear whether it's associated with the best survival outcomes. And the good news is that there are new therapies coming online, hopefully very soon, in the post-platinum, post-immunotherapy population. Thank you very much.
Thank you very much, Professor Jones. Do we have any questions on the floor here? Okay, seems to be that everyone is keen to go. Thank you very much. We're overdue in terms of time. Thank you, Professor. And we hope to see you in the future, inshallah, with us in person. Now I will just handle the mic to Dr. Iman Bukhari to start with the final satellite symposium and the final event of the conference.
Thank you, Dr. Isam. Assalamu alaikum. Actually, I'm very pleased to present our last speaker, who is a very dear and old colleague and friend to me, Dr. Iman Al-Hazmi. She is the head division of hematology and oncology in King Fahd Armed Forces Hospital. Dr. Iman, she will give us a talk about the role of pulanestrone in CINV. So the floor is yours.
Assalamualaikum. Good afternoon, everybody. I would like first to thank the organizing committee for organizing such a STEAM meeting, and then I would like to thank Tabuk Pharmaceutical for sponsoring this presentation. Thank you, Dr. Iman, for the nice presentation. It's nice to be in such activity and scientific meeting. To that, you meet all the friends. Thank you for sticking around till this time. I promise you my lecture will be concise and up to the point. We'll be discussing the role of palonosetron in the treatment of chemotherapy-induced nausea and vomiting. To start with, we are all familiar with the most common side effect that we see day to day with each patient, nausea and vomiting, alopecia and infection. Still, one of the most feared side effects of all of those is nausea. And for nausea and vomiting, of course, we are all familiar as hematologists and oncologists that they can be divided. The chemotherapy can be either categorized as high, emetic, moderately emetic, or low risk. And plus to that, we look at the categorize nausea and vomiting based on the time in correlation with chemotherapy. So it could be acute if we within the 24 hours of giving chemotherapy, or delayed after that, anticipatory when the patient comes already, they know there is a chemotherapy, they're gonna get a chemotherapy next day, they start to have this nausea and vomiting, or refractory when a patient giving an anti-emetic regime and still they develop nausea and vomiting. Nausea and vomiting effect on quality of life has been studied in the literature extensively, and multiple research showed that effect, it impaired quality of life for patients. One of those is a prospective multi-center and multi-international national study. It included almost 300 patients. They used diary of patient to write how frequent and how much they complain of nausea and severity, and they also asked the patient to complete functional living index MSs. Of course, they looked and they evaluated this over at the time, or the first day and then on day 6. The nausea had a more impact, even more than vomiting. Patients usually do not like to eat or avoid any eating. They cannot interact with the family or socially because they are afraid of nausea. In this study, they noticed that the nausea is much worse impact or negative impact even from vomiting. And of course, highly emetic chemotherapy has higher tendency than moderate emetic therapy. We have different categories and different classification of anti-emetic therapy based on the mechanism of action. And usually we use a combination to try to hit more than one area, because usually one is not enough because it's complex how chemotherapy induce nausea and vomiting. If we looked quickly in a summary on the baseline or guideline of treatment or anti-emetic regime for patients receiving chemotherapy, most of the time, especially if the patient is receiving moderately emetic or high emetic chemotherapy, at least 3 combination of anti-emetic regime medication could be used to cover more than one area, including serotonin receptor antagonist plus dexamethasone plus neurokinase antagonist plus or minus olanzapine. Of course, the low risk emetic or minimal, we don't usually need to give any anti-emetic, and we can see, especially in the acute and also in the delayed nausea and vomiting, different medication and multiple combination is required to cover the nausea and vomiting for patient. This is the Esmo guideline, and even NCCN guideline, they recommend giving multiple and different classes, including serotonin and receptor antagonist, plus NK receptor antagonist, plus dexamethasone, plus or minus olanzapine. I remember just 2 days ago on Thursday, I saw my patient for the second day of chemotherapy. And when I asked her, how are you? She said, I was about to die. I was about to die. This chemo is really bad. What are you giving me? Although she's receiving chemo, she received chemo previously, and now she's receiving chemo for relapsed leukemia. And when I asked her why, she said because of the nausea and vomiting. She felt, and this is the most severe severity of nausea. A patient complained to me that she felt to the extent that she was about to die, even though she was an antiemetic therapy, but still she had a bad nausea and vomiting. Palinositron in the management, what is the role for it? We'll have a quick review on the on different article comparing palinositron. What it is to start with, it's highly potent and selective second generation serotonin receptor antagonist, and has much higher affinity for the receptor than we see in the first generation antagonist. Additionally, it has an extended elimination half-life, which is 40 hours in comparison to maximum 9 hours in the first generation. This is a diagram showing the nausea, how it happened acute and delayed with, for example, cisplatin, and how different classes and different medication act. And we could see palinositron half-life extended up to 30 hours, which can cover the acute and delayed nausea. It has a specific characteristic of when it binds to the receptor, it's what they call it allosteric binding, in which it causes conformational changes leading to internalization of the receptor, and add to that it break the cross-link activity with NK cells, and this is considered NK receptors and signaling, and this might explain the efficacy in delayed delayed nausea. So one of the studies that compare palinositron to ondansetron, they had 3 arms, small dose and the higher dose of palinositron, and ondansetron 32 milligram. None of the patients received the steroid as a treatment for antiemetic, and for a single dose, it was double-blinded study, and it included 563 patients with chemotherapy. The primary endpoint was the proportion of patients who had no emetic episodes and no rescue medication, and this is what it's called the complete response during the first 24 hours after chemotherapy. And the secondary endpoint looked into the efficacy for delayed nausea, 5 days or less, and overall tolerability. In comparison, whether for the acute or the overall, palinositron showed a better response rate and better control of nausea in comparison to ondansetron. And this is another comparison between the same class for the first and second generation, but in this one they allow the use of dexamethasone, and patients usually receive anthracycline plus cyclophosphamide regime. It was post-hoc analysis on 1,114 patients, and you could see a significant difference for palinositron arm, in specifically treating the delayed nausea and overall incidence of nausea. When they looked into comparable the days, different day 1, 2, 3, 4, 5, we could see a prominent effect and incidence and severity of nausea even in the arm of palinositron. So, and again, this could be related to the mode of action in which it binds, in internalization of the receptor, the longer half-life, plus the breakage of cross-link with NK receptors. Another what else they found when they look into patient categories, they found the patient who did not develop acute or delayed nausea were female, younger age group, and who received the cisplatin. Those patients were more probably respond well to treatment, and patient who specifically did not have improved dramatically for the delayed nausea were older patient or received the doxorubicin, epimeralism. So they concluded in this study that paltusotine is more effective as a prophylaxis in case of highly emetogenic chemotherapy, especially in delayed nausea and in overall incidence of nausea. A systemic review that was done comparing paltusotine in the prevention of chemotherapy-induced nausea and vomiting, and they looked in all studies that compare paltusotine with first generation, and they only include homogeneous study to make sure to minimize differences. The primary outcome was complete response, so there is no acute delayed and overall phases of chemo-induced chemotherapy. And secondary outcome included the adverse event of paltusotine. The meta-analysis confirmed the difference in favors of paltusotine in the prevention of acute nausea and vomiting by 24% and of odds ratio of 0.76, delayed chemotherapy-induced nausea and vomiting with overall with odds ratio of 0.6 to an overall phase. Also in favor of paltusotine with odd ratio of 0.64. Subgroup analysis showed statistically significant difference in favor of both two doses. Both doses, 0.25 milligram and 0.75 milligram, are effective, but the difference between these two doses is not really statistically significant. Even in the previous, the initial study that we mentioned, they both are effective. The smaller dose is as effective as of the 0.75. And here just a few information about the medication for the patient dosing and administration. And by this, I conclude my lecture. Thank you very much.
So thank you very much, Dr. Iman. It was very elegant presentation, but let's see if there is any questions from. So I might give you this one.
Thank you very much, Dr. Iman. That was excellent review. My question that you presented that for a patient with elderly patients, you can see that the delayed emesis is less comparable to the young population. We know that females, they have a higher incidence of nausea and vomiting for different reasons. But the point that, so do you recommend that paltusotine can be only for young people intensive chemotherapy, because in frail patient or in elderly, they also susceptible for the vomiting and the delayed emesis, as you pointed out, it's an important issue. So we believe that both categories can be candidate for the treatment. So what do you think?
I think we need, even though the patient factor are important, but still we know that the chemotherapy, how each one is different, and we know which is highly emetogenic or not. So Like the patient who told me I was about to die just because of the nausea and vomiting, she's 67, old lady. Yes, she's a female, but she's really old. So I would keep in consideration first is the chemotherapy, although there is a lot of report about that. And that's why in that study specifically, they want to analyze the factor that's related to, but I would look into how intense and highly emetogenic the medication is.
Thank you. So do you think that pulsatron is working mainly in the delayed more than the acute, or it working in both? Because we do have in the INSI guidelines the aprepitant, and also we can see in the same category the pulsatron as well. So what is your recommendation specifically that we do have as a center? We have a grelcitron and we have aprepitant for as well. So do you think the pulsatron, it needs to be in our category as well?
Yes, I think it is required because first, even with those medication, still a patient receiving whatever we are giving them nowadays, and still they have nausea and vomiting, still requiring treatment frequently. Still with a combination, we give patient ondansetron twice daily. Sometimes we add much more, and still the patient complain of nausea and vomiting, and that in the acute and delayed. So if we know that this medication or the chemo protocol have the tendency to give to cause delayed plus the acute, so I would give a medication that covers all.
Thank you very much, Dr. Iman. It was very informative presentation. Thank you, Dr. Merfat. So, Dr. Hassan.
Okay. Now we come to the end, but every end is a new beginning. Thank you very much for your participation and attendance. Thank you for the supporting companies. Thank you for event groups for their marvelous job as usual. Thank you for Dr. Merfat for the nice organization of this conference, Dr. Iman, Dr. Aisha, and thank you, Dr. Iman Hazmi, for attending with us and presenting this interesting data. Thank you very much, and hope to see you, inshallah, by the start of July for our ASCO update, which will be carried out in Riyadh, and it will be the first update just after the ASCO, and we hope to see you there. Okay, thank you very much. Have a blessed day. And also I'll take this opportunity to thank all the ladies and gentlemen who attended online. Okay, so we forgot that. Thank you very much. We have exceeded 16,000, alhamdulillah, which is really something very good. Thank you very much.